Good morning. My name is Petros Koutrakis. I'm a professor of environmental sciences at the Harvard School of Public Health. And it's a pleasure to introduce the chair of the second day, Dr. Stefania Papatheodorou. She's a lecturer in epidemiology at the Harvard School of Public Health, or T.H. Chan School of Public Health. And she's a trained obstetrician, and she received her PhD in epidemiology. Also, she has a master's from the Cyprus International Institute in epidemiology and biostatistics. And she will chair the session today and introduce every speaker separately. Before I pass the floor to Stefania, I think we had a very good session yesterday. Most of the presentations focused on exposure, and today we are going to talk about health effects. It seems that there is still a lot to do about understanding the air quality in a large region. But I was encouraged by the studies I saw yesterday that source apportionment in Qatar, in Kuwait. And so I think in the near future, probably more research will be done to understand the sources of air pollution, to understand transboundary pollution, the effects of climate change on air quality. There are many, many issues that they need to be addressed and provide the policymakers with the right information to make decisions. So I hope today to delve into the health effects. Many years, about 10, 12 years ago, people thought that dust storms did not represent a risk to the population, because these particles are natural particles and people have been in the desert for thousands of years. But what we have learned since is that dust, it can be toxic. It can be a vector carrying different microorganisms, metals, radioactivity, and that it should be considered as one of the environmental risks. In addition, the region faces serious climatic changes, and we hope today to talk about this as well. So Stefania, I pass you the floor, and you take over from here.
Great, thank you so much, Petros. Good morning or good afternoon, everyone, depending on your location, and thank you all for joining us on the second day of this webinar. As Petros said, I am Stefania Papatheodorou, and I really appreciate the opportunity the organizers gave me to chair this session. Today, the session will focus on health effects of air pollution and climate change, and we have an amazing lineup of speakers that are going to cover a wide range of topics. Each talk will be 15 to 20 minutes long, and we'll have the opportunity to answer one or two clarifying questions after each talk. Then we have a discussion section after the first four presentations. So without further delay, I will introduce the first speaker for today, who is Dr. Eric Garcik. Dr. Eric Garcik is an Associate Chief Pulmonary Allergy, Sleep and Critical Care Medicine at the VA Boston Healthcare System, a professor of medicine at Harvard Medical School. He received his MD degree in 1979 from Tufts Medical School and a Master of Occupational Health from the Harvard T.H. Chan School of Public Health. He's a board-certified physician in internal medicine, pulmonary disease, and critical care medicine. And as well as practicing medicine, he has expertise in the health effects of air pollution with a focus on the effects of particulate air pollution and diesel exhaust on health. He has done a lot of work on the health effects of exposure to particulate matter in the US military personnel previously deployed to Iraq and Afghanistan. So, Dr. Garcik, the floor is yours.
Okay, well, thank you. And let me, yeah, perfect. Yeah. So my task today is to give an overview of the health effects of air pollution, and we're going to focus on particulate air pollution And you'll hear much more about some of the topics I've speaking about today later in the presentations. Next slide, please. Today we're going to give a historical perspective, talk about particle deposition and clearance, talk about the mechanisms of particle toxicity, evidence for short-term effects on cardiovascular and respiratory health, disease development, heart disease, reduced lung function, FEV1 and COPD, lung cancer, diabetes, and a little bit about susceptibility. Next slide, please. So the sentinel event linking air pollution to mortality was the London fog that occurred in 1952. And you can see a picture of the London fog with a bus with its lights on. And I can show you, this is a picture of Kuwait City in a sandstorm, perhaps a modern day London fog or Kuwait City fog. And in London at that time, there was a lot of heating with coal and oil. Diesel buses had just replaced electric trams in July of 1952. There was an aversion over London. And the graph you see in the lower left of your slide shows smoke measured in the air, and a day or two later, an increase in deaths that persisted until the next 3 months or so. And in 1 week, there were 4,500 excess deaths, and through March of 1953, over 13,000 excess deaths, and people died of bronchitis, influenza, although there was no flu epidemic, pneumonia, and heart disease. And in archived tissue samples left from that time, studied in modern imaging, there is a carbonaceous aggregates of carbon particles in all lung compartments. So these lungs really overloaded with carbonaceous air pollution. Next slide, please. The study that linked long-term exposure to particularly air pollution and mortality was the Harvard six-city study. And this is an example of, this is data from their extended follow-up. So the first period, mortality was examined in 6 US cities between 1979 and 1989 using a central site monitor. And the finding in that time period was a increased mortality that ranked with the PM2.5 values. And if you look at the graph on the left, you can see how the PM values came down during the course of the study from 40 micrograms per cubic meter down to the range of 25 in the dirtiest city, where the cleanest cities had ranges of values of 10 to 15 micrograms per cubic meter. And the mortality in the period 1 was elevated, 1.18 for overall mortality, increased cardiovascular mortality, with suggestive effects on respiratory mortality and lung cancer mortality that have really been confirmed going forward. Now you can see that the mortality experience decreased over time. The PM levels rather decreased over time, and if you looked at the decrease in PM 2.5, subtracting period 2-1 levels and adjusted for mortality in period 1, there was actually a decrease in mortality to 0.73, a 27% reduction, with a decrease in cardiovascular and respiratory mortality over that time period, indicating that if you mitigated the increased PM 2.5 levels, you'll have an improvement in health. And now this has been also studied many times, but this is a study that really shows the benefits of reducing PM 2.5 levels. And of course, these levels are far below the levels we talked about yesterday in our exposure assessment in the Middle East. Next slide, please. So this is a picture, a schematic of an air pollution particle from a combustion source that consists of solid carbon spheres that agglomerate to make slightly larger agglomerates, but still are very small in the less than a micron or less, and many in the ultrafine range. And coated on these carbon particles are organic compounds that are carcinogenic, metals and other chemicals. And it's thought that these carbon particles act as a vector for these other chemicals and metals into the lower respiratory tract. And in fact, this black carbon can be measured as a marker of exposure in other particles that are collected. Next slide, please. So where do these particles land? And you can divide the respiratory system into 3 components: the nasopharyngeal region, the tracheobronchial region, and alveolar region. If you look at the graph up on the right, you'll see that ultrafine particles will deposit in the nasopharyngeal area, which is implications for transport that I'll talk about in the next slide, where particles less than a micron or less deposit both in the tracheobronchial region and the alveolar region of the lung, and the PM2.5 fraction captures this lower fraction that is very likely responsible for the toxicity of PM2.5. Next slide, please. So when you inhale these particles, where do they go? And so based on animal studies in the nasal region, there's evidence that ultrafine PM can be transported in the olfactory apparatus back into the brain. In the airway region, particles between a micron and 10 micron deposit. These are cleared relatively rapidly by mucociliary clearance, beating cilia, airway macrophages. And then, but in the alveolar region, the particles that deposit have a residence time of a couple of days, but to months. And these are cleared by alveolar macrophages, but also particle translocation across the alveolar, across the alveoli into the lymphatics and blood, where they can be transported to other organs and cause systemic effects. And in fact, we'll hear about this more later in the discussion, in the talk about birth outcomes, but recent studies have demonstrated carbonation PM in placental tissue. Next slide, please. So what are some of the mechanisms now of PM toxicity after deposition in the respiratory tract? And you can kind of see three main pathways, perhaps central nervous system transport, lung inflammation, and then translocation, rather deposition in the respiratory tract with translocation to the blood, and lung inflammation. And the lung inflammation presumably spills over to cause systemic inflammation. In the setting of lung inflammation, there are sympathetic receptors in the lung that can cause autonomic system dysfunction that may cause that dysregulation of the cardiovascular system. There's evidence to suggest this when you studies looking at cardiac arrhythmias, systemic inflammation causing cardiac dysregulation, vascular dysfunction, and increased clotting, which is also contributed to by blood-borne particles causing systemic effects, which lead to cardiovascular complications. Next slide, please. So this is the largest study to date, and there are many, examining daily mortality in response to a rise in PM2.5. And these authors studied 652 cities around the globe, and still mainly many in China and in the US contributed. There are really few from our region of interest in the Middle East. Now the PM annual median was 32 micrograms per cubic meter with a wide range of 4 to 117. And all-cause mortality, when you examined a 2-day average of PM2.5, went up 0.55% per 10 micrograms, with a significant increase in cardiovascular mortality and respiratory mortality. And this was increase in PM2.5 was also observed in 2 pollutant models, really implicating PM2.5 independently of gases. This is the effect across the entire range of PM2.5 in the graph on the right. And you can see that the graph is slightly curvilinear with a bit of a plateau at the highest levels of PM2.5 between 100 and 150 micrograms. But there was an effect on mortality throughout the entire range of PM2.5 and across all the air quality standards, WHO, the US standards, and the China air quality standards. So there appears to be really no threshold of this effect on mortality. Next slide, please. Now, in terms of causing long-term mortality, there is evidence that exposure to PM2.5 actually causes disease. So there are studies looking at carotid artery thickness, and you can see on the right picture here of how of where this lives in the common carotid artery. This is an artery in one's neck that supplies the brain with blood, and you can measure this based on ultrasound in a very standardized way. In a meta-analysis of 5 U.S. trials, with a mean PM2.5 still very low, IMT progression, the thickness of the carotid artery, intermediate thickness, was related both to average PM2.5 and a separate effect on living near a highway, indicating that PM2.5 causes progression of atherosclerosis. You can also image the coronary arteries using CT scans, and the coronary artery calcification score is a predictor of coronary risk. And what was found in a very large study in the US over 10 years, in the MESA-EAR study, there was an increase in calcium score across the entire range of PM2.5. I'm not sure you can see this down at the bottom, but there was a fairly continuous effect of increased PM2.5 and increase in coronary artery calcification score. Next slide, please. Now, what about reduction in pulmonary function? And the way this is measured is having a patient breathe out as hard and fast as they can. I used to make a mark on a rotating drum with paper. This is now computerized, and you generate a number called the FEV1, the forced expiratory volume in 1 second, which is the amount of air you move out in 1 second. The FVC is where there's all the air is moved out, is exhaled out of your lung. And there's a number of studies showing this. I've selected a couple of the higher quality studies. There was a study in the UK, in the US Biobank study, where spirometry was done between 2006 and 2010 in people aged 40 to 69. And land use regression model linked these spirometric estimates to their home address. And for every 5 microgram increase in PM2.5, there's a decrease in FEV1 of 83 mils, which is a rather large decrease, and a decrease in FVC and FEV1 over FVC. And this ratio is a marker of airflow obstruction. And when you look at the lower, below the lower limits of normal of this ratio, in 7% of the population, the increased odds of developing developing what was called COPD, or airflow obstruction, of a 50% increase. There were very, very few longitudinal studies, however, and one such study in the Framingham, Mass cohort, where spirometry was done 2 times between 1995 and 2011, and these numbers were linked to a PM2.5 land use regression model. And for each 2 microgram per cubic meter increase in PM2.5, there was a 13 mil decrease in FEV1, and longitudinally there was a 2.1 mil per year decrease that was significant. And these over a population are significant values. Next slide, please. Now, we've not talked about cancer, but in fact, in 2013, a PM2.5 was considered a group A lung carcinogen, group 1 lung carcinogen, as with diesel exhaust in 2013. And this is similar to the classification of smoking and asbestos. And in 14 studies of PM2.5, the risk per 10 micrograms of PM2.5 was a risk of 1.9, which was significant. And when you looked at incidence and not mortality of lung cancer, the risk was even greater, a 1.25 increase in mortality, and rather in incidence of lung cancer. Next slide, please. Now, we've done work here in Boston on diesel exhaust and lung cancer mortality. And this is a meta-regression of 3 studies with quantitative risk estimates. Higher of estimates to the right are in coal miners, where they run underground diesel engines. And the estimates on the left are some of the lower estimates among coal miners plus trucking company workers, recognizing that truck drivers on the highway have the same exposures that we have driving on the highway. And there's a nice, a curvilinear relationship between cumulative exposure to elemental carbon, representing the carbon core of those combustion particles, and lung cancer mortality, where the risk estimate predicting a 21 excess lung cancer deaths for an environmental exposure of 0.8 micrograms per cubic meter, which is relatively low compared to some occupational exposures and exposures in the dirtiest cities around the world. And based on these data, I believe many countries are phasing out diesel engines in their light-duty vehicles, such as India. Next slide, please. Now, what about diabetes? And I've been hearing a lot about diabetes in the Middle East. And based on two recent meta-analyses, there's a relationship between causing diabetes, new onset diabetes, and PM 2.5. And two meta-analyses were written at about the same time, 2019 and 2020, and they came out with the same answer, which is good news, of course, with a risk prevalence of risk odds ratio of 1.09. Incidence of 1.10, with similar effects from the other risk assessment, the other meta-analysis rather. But this second author studied glucose increase, where per 10 micrograms of PM 2.5, there was actually worse blood sugar control among diabetics. Next slide, please. Now, here at Boston, we've studied effects in patients with COPD, looking at acceptability. And it's actually not clear who really is more susceptible or not. I think age is one risk factor, but whether persons with underlying systemic inflammation and other problems are definitely affected more requires some additional study. This is also evidence that you don't have to do very large studies to get close to the biology of how particles affect health. And at my hospital, we studied 144 participants with COPD with repeated measures of exposure 4 times a year measured inside in their home, since people spend most of the time inside their house. We took people who weren't smoking, had no sources of indoor black carbon. So therefore, the indoor black carbon represented outdoor black carbon infiltrating in, mainly from traffic. And we measured exposure the week before in their home, and did spirometry and collected blood samples when they came in after the exposure assessment. And we measured C-reactive protein, which is a protein synthesized by the liver, and it goes up in response to an inflammatory stimulus, and is a marker of cardiovascular risk. Next slide, please. And when you look at black carbon measured over the week, looking at moving averages and day 1, average over day 1 to 2, day 1 to 3, day 1 to 4, before measuring the blood, measuring CRP and the integrated sample, the top squares, the clear squares, are non-statin users, statins drugs that are given to reduce cardiovascular risk. And you see that the persons not taking statins had a higher CRP, a 20% increase for interquartile range. And when you go to the right panel, you can see adjusting for statin use, the effect on diabetics. Patients with diabetes and with COPD had a greater increase in CRP than a patient without diabetes, suggesting that diabetes and not taking statins, which may be one way of mitigating some of the effects of pollution, are associated with higher levels of systemic inflammation. Next slide, please. So just to conclude, fine particulate air pollution has pulmonary cardiac systemic effects that result in illness and greater mortality. The most influential studies to date have not been conducted in the Middle East or India. And the mix of these pollutants that can include desert dust, which is unique, and pollutants from vehicles and industrial sources are very likely adversely affecting the effects of person in the region. And I believe a focus of this conference and going forward should be ways to mitigate these effects and to study them further. So let me end with that.
Wonderful. Thanks a lot, Dr. Garshik. we have time just for one question. There is one question in the chat that says that does the inhaled PM of any size affect cilia, either cilia beat frequency and or rhythm? And can that be directly or indirectly via inflammation?
Yeah, I do not know that direct answer to that question. I do know that patients with COPD do have reduced airway clearance of these particles. And for example, when you smoke cigarettes and you have inflammation and increased mucus in the airways, you ultimately will develop loss of cilia and the clearance will be worse, be reduced rather. So perhaps that's an indirect answer. I don't know if you take somebody with normal airway clearance or normal cilia and you put particles on them, will you reduce the ciliary beat? I do not know that.
Okay, great. Thank you so much, Dr. Garshik. And we'll move on to the next speaker, who is Dr. Barak Al-Ahmad. He's going to talk about climate and health. Dr. Al-Ahmad is a PhD candidate in population health sciences, specializing in environmental health at the Harvard T.H. Chan School of Public Health, and a mission scholar from the Faculty of Public Health in Kuwait University. He holds a medical degree from the University of Liverpool in the United Kingdom and a Master of Public Health from the Johns Hopkins Bloomberg School of Public Health with a concentration in global environmental sustainability and health. He's working with his advisor, who is Petros Koutrakis, on air quality, climate change, and health in the Middle East, specifically the adverse impacts of dust storms and extreme temperatures. So, Dr. Al-Ahmad, the floor is yours.
Thank you very much. Nice introduction. Okay, let me just put up my slides here. So I am going to talk about climate change and health, but specifically in inherently hot regions. And I'm going to use Kuwait as one case study. So climate change and health, when we talk about this, I mean, there are multiple pathways in which climate can affect health. And the CDC here, for example, they have outlined these numerous pathways. So you have things like severe weather or air pollution, vector-borne diseases, allergies, and you can go on and on. One also important thing is water shortage, food shortage, etc. And then one simple wedge of that, really a lot of different pathways, is the heat. And I'm only going to talk about this part here. If you look at the IPCC, for example, I mean, that what we saw previously was the CDC. But if you look at the IPCC, they also have different pathways and they look into the impacts of health in a different way. So they have the direct impacts, in which the increase of the temperatures outside will cause a heat exposure and that would affect health. But they also talk about the indirect impact. And we've seen this from presentations yesterday on how does the health, how does all the ecosystem mediated things, how does the climate affect the air pollution or dust storms and things like that. And but for this presentation, I'm only going to stick to the one here, the pathway here at the top, which is the direct impacts leading to heat and human health. But when we talk about heat, we mainly talk about, I see, things about change in the mean of the temperature or increase in temperature mean. And if that's the case, then we're looking into just a shift. If you think about it, if it is shaped like this, and then you can just push the distribution towards the right, and that will give you more exposure at the tails here. But actually, there's also an increase in the variance. So an increase in the variance would also result in having, wider tails. But what's happening with climate change is that we're getting both an increase in the mean, which is the shift that we're seeing, and also an increase in the variance, which is how this curve get depressed, and then you get all these things at the tail. So think about it, if a country or a region is already on this hot tail, what would that mean for it to be if there is an increase in temperature mean and variance? In terms of how frequent the heat, the heat impacts will be, or what's the magnitude of pressure, and so on. But let's talk about the Middle East for a minute. So I've come across a number of studies that examine projections and looking into the effects of heat on mortality. And there are two key studies here that I quoted from. The first one, they say that under the business as usual scenario, which is if we continue emitting what we're emitting right now, the results expose a specific regional hotspot, which is the Arabian Peninsula, where climate change is likely to severely impact human habitability in the future. Now, that is such a big question here because the authors think that, well, according to the models and what we're seeing, there is a question mark with regards to human habitability because of the extreme temperatures. And another paper showed that the mortality risk will increase in the distant future by 8 to 20 times higher than the historical period. So this is why when we talk about the Middle East and the heat studies, which is different a little bit from the studies that are done in Europe, we're looking into a high magnitude of exposure and an amplified exposure in the future in light of climate change. But when we measure heat effects or look into heat studies, what is the outcome? And one of the things that get brought up many times is heat stroke. Well, I mean, you can die from heat stroke, and that could be one thing that we can take and measure. But there is an ICD-10 code, by the way, for heat stroke, which is T67.0, heat stroke and sunstroke. Now, when you write a death certificate, you need to put the disease and condition directly leading to the death. But this doesn't happen as much. And I'm a physician, and a lot of people that in here are also physicians, and they know that this doesn't happen. I don't know for whatever reason is there. But if you only rely on heat stroke as your outcome and looking into the effects of temperature, then you're going to run into two problems. The first is that there is a chronic underestimation in the diagnosis of heat stroke as a cause of death. So there could be another cause that is being put there. But actually, if you don't look at heat stroke for a minute, heat can actually exacerbate existing conditions and become contributing factor to death, not directly leading to death, but can be contributing factor. And if you only look at heat stroke, not only you're going to get very few observations because of the chronic underestimation, but you will be ignoring a big chunk of deaths that are happening because heat is being the trigger, but not the direct cause of death. So for that, many epidemiological studies, they rely on total non-accidental mortality, or you can look into things like, for example, cardiovascular mortality, respiratory, and so on. So why Kuwait? Why did we pick Kuwait as a case study? Well, first, because I am from Kuwait, but the temperatures in Kuwait are rising to unprecedented levels. And I showed two pictures here. These are from social media. It's been circulated. Someone trying to cook an egg on the asphalt, which cooked. There's I think a YouTube video about it. You can see that traffic lights are melting from the extreme temperatures. But that is one thing. And then if you look at the literature, the World Meteorological Organization did an evaluation for an observation of 54 degrees Celsius in Kuwait. And I quote from them that this is the highest officially recognized temperatures to have ever been recorded in the last 76 years. So we're getting very hot temperatures that are already being observed in Kuwait, which led us to ask this question. Now, what is the effect of temperature on mortality risk in Kuwait, given that the temperatures in Kuwait are already high, and then Kuwait is in a hot, hyper-arid region? And then we looked into the effect of the 99th percentile of temperature, meaning the temperature at the tails, the hottest temperature recorded throughout the year, which was about 42 degrees Celsius on average. That's a 24 average. And then you compare this to the optimum temperature, which is the temperature that is associated with the least mortality. And then you can see, if you do this comparison, you get a relative risk of total death, that is a total non-accidental death, of 1.65. Now that is 65% increase in the risk of mortality comparing that day with a 99th percentile of temperature, the day that was 42 degrees Celsius, compared to that day with a 32 degrees Celsius, which is the optimum. Then you can choose another threshold. Instead of the 99th, you can choose the 97.5, 95th, 90th. And you can see that there is some attenuation, but this is something alarming. Now, what we did next is that we went and toned down on the outcome of interest. Instead of looking into total non-accidental mortality, now we're looking into cardiovascular mortality. And then we looked into how does heat affect cardiovascular mortality in Kuwait and what implications this might have for climate change. And the result is confirming, but actually showing a higher magnitude. So now we're looking into cardiovascular mortality in Kuwait, and then comparing the 99th percentile to the optimum temperature, the relative risk of cardiovascular mortality is 3.09. Now that is a doubling to tripling of the risk of dying from a cardiovascular cause on that 99th percentile of the days. So let me just say this thing here, and these are all observed temperatures and observed relationships in the past. So the data that we use is from 2010 and 2016 or 17. So we did not yet look into the future when we know that with climate change, temperatures are going to rise. But this is all from historical observed already relationships. And that is something that we need to look at. But before we do that, we need to have the next question, which is, what is the vulnerability to temperature mortality in Kuwait? Meaning, Eric was just talking about who are the vulnerable subpopulations. What about susceptibility in Kuwait? What do we know about that? And then the problem with using relative risks or looking into the risk using a temperature related death study in the US, let's say in a city like Chicago or Phoenix, Arizona, or something like that, and then try to generalize this to Kuwait or to any other country in a different region, is that the underlying population could be different. So the susceptibilities and the vulnerable subpopulations could actually be something different because we have different prevalence of diseases, we have different composition of the population, and many other things that can play a role. But in the Middle East, we may have different vulnerable subpopulations. And when we did the study, we found that men, the elderly, the non-Kuwaitis, which is the migrant worker population in Kuwait, and people with cardiovascular diseases are at high risk of dying from heat and the extreme temperatures. But let's just go through some examples and show how this might differ between different regions and why do we need something with local context and studies of local context that can provide some information and additional information. So let's look at males, for example. The risk of death from heat exposure was significantly high among males. Now, we looked into previous studies. Some studies show that there is no difference between males and females. Others show that it is higher among males, and some show that it is higher among females. Now, what this tells you is that susceptibility by gender could be contextual within a geographic and socioeconomic factors. Now, we know in Kuwait, there are cultural norms that can play a role in determining outdoor exposure, like choice of clothing, staying indoors, etc. Let's take another example. The non-Kuwaiti population. The risk of death from heat exposure was significantly high among the non-Kuwaitis. Now, the non-Kuwaiti population comprises mainly of male laborers who are usually in working age group. They are more likely to take more demanding job and then get higher exposure to heat. And this is not a unique finding for Kuwait, because as you'll see in the when Susanna does her presentation, the study that she did on air pollution and dust storms in Kuwait, she also showed that non-Kuwaiti males are at higher risk of death. So that is something Now we're getting into nationality here being an effect measure modifier. And to just show why we care about the local context and how important is it to just do studies that are specific to a certain region, if you look at the Kuwaiti population and you look at the population pyramid, it looks nicely symmetrical, consistent with any developing country. You get a younger population, little elderly population. But then if you look at the non-Kuwaiti population, you see a big skew here towards men who are in middle age, working age. And that leaves the total population pyramid looking something like this. Now, if you do a time series study looking only at total population, then you might be missing something. You might be missing where the effects is happening, which subpopulation is getting more vulnerable. Now the thing about nationality might be unique for Kuwait, but it's not so unique when you compare Kuwait to Bahrain or Qatar or the UAE or Saudi Arabia, maybe to a lesser extent. But these things are common within the region, but are not so common to have a nationality being an effect modifier, maybe in European countries or in South Asia or other studies. So this is why the local context now here becomes important in understanding the effects of heat on mortality in light of climate change. But what's next? Now, we did all this using previous currently observed temperatures up till 2017 or 18. What about the projections? Now, there are 4 different pathways for how the temperatures could go depending on climate change and how do we see it. The highest emission pathway, which is the business as usual, and there is the lowest emission pathway, the RCP 2.6. Now, we wanted to look into how does mortality change into the future in Kuwait, but we picked the RCP 4.5 for now. And we think, I mean, that is, if the world now decides to do something really drastic and change everything, maybe RCP 2.6 could be a little bit out of reach given the current state that where we are right now. So we said, fine, let's not assume that is going to be the worst thing and people are just going to continue emitting right now. We're going to choose what we think is the most optimistic scenario, which is the RCP 4.5. And we did that. Now we're currently doing it. We're looking into temperature mortality projections in Kuwait for the immediate future from 2021 to 2060. And right off the bat, when we did the modeling looking into the future temperatures, the average increase in mean temperature under the RCP 4.5 by 2060 in Kuwait was 1.84 degrees Celsius. Now that is higher than what the Paris Agreement and the Paris Climate Accord of 1.5 target. But what's more revealing is that when we looked at the model data, the one in green here, first, what we did is that we compared them to the historical data that we had to just see how good, how well does these predictions do. And we can see that the model data overestimate cold in Kuwait and they underestimate the peaks of heat in Kuwait. So that is important. Now, then we did the calibration with using the historical data, and then we get into this number and how much is it going to be by 2060. So we're talking about 1.84 degrees Celsius increase. Now, if we translate this into projections of mortality using a lot of other assumptions, you compare the 2050 to 2060 future period under this climate scenario, which is very optimistic, historical period, and the excess mortality from heat in Kuwait is about 3%. That is attributable to climate change. Now, what I want to do here is just talk about the case which would summarize why we have to do some Middle East collaboration, given that we have some different features between different countries, but we also have a lot in common in terms of the exposure distribution. So first, there is a unique contribution for a Middle East collaboration because, which subpopulations are more vulnerable? Now, this is a question that we can explore and we can find which subpopulations are at highest risk that is specific to this region. And that's something we won't know until we examine this. We might have some theories. There's also important information for decision makers to make interventions to protect public health, which is very much needed with regards to climate change, but there is a potential for broader impacts. We need to grow the literature from the Middle East region to help with understanding the climate effects in general. How does climate affect health, especially heat? And but finally, fulfilling the commitment with the, we need to submit climate adaptation plans for the Paris Climate Accord. And without having the proper science to support these adaptation plans or mitigation plans, this would not be possible. So my take-home messages: in this hot and hyper-arid part of the world, population health data is not abundantly available, and that is a problem for the region. But at the same time, temperatures are soaring to unprecedented record high levels. And we uncover vulnerabilities to temperature extremes from a region that is overshadowed by a question of human inhabitability by the end of the century because of the extreme heat. And we ask serious environmental justice questions that need to be addressed by policymakers that could be exacerbated by climate change. Things about migrant worker population, how they are affected differentially compared to the nationals. And finally, there is an alarming evidence that is growing and emerging on cardiovascular mortality from heat exposure that we also need to explore. And finally, there's more research that is needed in this region. So thank you very much. I would like to thank people at Harvard School of Public Health, Johns Hopkins, the London School of Hygiene and Tropical Medicine, Kuwait Foundation for Advancement of Science. I'm going to keep going on, Stephanie, for a minute. The Ministry of Health, Kuwait Institute for Scientific Research, Environmental Lab, Faculty of Public Health at Kuwait University, US EPA, and Kuwait EPA. That I can stop.
Wonderful. Thank you so much, Dr. Al-Ahmad. I don't see any questions in the Q&A chat box, and we are a bit behind, so I think we should move on to the next speaker, who is Dr. Panagiotis Giallouros. He's a professor of pediatrics in the University of Cyprus Medical School and a trained pediatric pulmonologist. He's the head of respiratory physiology laboratory and primary ciliary dyskinesia service at the University of Cyprus. He's also the project coordinator of Life Media and participates as a work package leader in other projects focusing on respiratory disease and public health. And Dr. Giallouros is going to discuss about the effects of dust storms. So Dr. Giallouros, the floor is yours.
Thank you, Stefania, for the introduction, and allow me also to thank the organizing committee for giving me the opportunity to contribute to this webinar. Right, so in the next 20 minutes, I'm going to give you an overview of the short-term effects of desert dust on respiratory outcomes, focusing primarily on the results of a systematic qualitative review of the available data that we are undertaking with our team in the last few months. So we're going to talk on the associations of desert dust with respiratory mortality and indices of respiratory morbidity, such as hospital admissions, emergency department visits, and for all respiratory causes, asthma, COPD, and pneumonia. And at the end, I'm going to touch a little bit on the very little cumulative or chronic effect data that we have for desert dust. As you probably all know, the desert dust has been repeatedly associated with health effects across different populations. And respiratory as well as cardiovascular effects of desert dust are among the most frequently assessed outcomes in these studies. A variety of respiratory outcomes have been assessed to date, ranging from subtle changes in respiratory symptoms to changes in morbidity indices such as hospital admissions and emergency department visits, and of course to respiratory mortality. And so far, previous narrative literature reviews provide an inconclusive picture on the direction and magnitude of these associations between desert dust and respiratory health effects. So in this regard, we feel that this review we're going to present now is going to be of use and help. Just in last year, we had the first publication that systematically reviewed and meta-analyzed data on the effects of desert dust on human health. That was a study coming from Japan that basically focused on the Asian dust effects on a variety of health outcomes. They just assessed dust days versus non-dust days and not the contribution of increments in PM10 concentrations. They reviewed 89 articles for the qualitative assessment and included only 21 in the meta-analysis they have performed. Here you see the forest plot for the impact of desert dust on mortality, all-cause mortality, circulatory and respiratory mortality. And you can see on the plot down on the right, the effects on respiratory mortality that seem to be significant on lag 3, on day 3 after the events. The same forest plot for the hospital admissions across all lags appears on this screen here. And you can see that for respiratory morbidity, there are again strong associations on lag 3 for all respiratory causes, asthma, and pneumonia. And the authors of this publication, of course, conclude that there is a positive association between Asian dust exposure and mortality and hospital admissions for circulatory and respiratory events, but they underline the small numbers of the studies that had eventually been included in the meta-analysis and the need for further evidence, as well as the great heterogeneity in the definitions of the dust days that have been used in these original studies, and the also wide variation in the study designs, the control for confounding, and the models that have been used in the analysis. So we have undertaken these systematic reviews of the literature on the effects of desert dust on a variety of health outcomes. Here I'm going to present to you some basic features for the respiratory health, and later on Susanna Hilleo is going to talk more on the cardiovascular health effects. We searched the 4 main electronic databases since their inception and until July of last year, with a set of appropriate key words. And eventually, for the qualitative synthesis of the respiratory health effects, we selected 42 studies, as you can see from the flow chart on the right, 14 for the respiratory mortality and 28 for respiratory morbidity. On this graph here, you see that the majority of the papers for the respiratory outcomes were published in the last 10 years, and the duration of data collection was ranging from 1 to 14 years. And as far as the geographical distribution of these publications is concerned, you see that the great majority of them come from Europe and Far East, while a substantial portion is also coming from the Middle East countries. Now, in these selected studies, there are basically 2 study designs. The first is the time stratified case crossover design using logistic regression, and the second is the time series design using Poisson regression. In the first design, basically we have assessment of the effect of dust storm days versus non-dust storm days on respiratory outcomes. The non-dust days are the comparison, the control days. And these are usually selected in a time stratified manner, as I said, by choosing the similar day of the week, usually 7 or 14 days before or after the event. In the time series design, the studies basically assess the change in the risk for the respiratory outcome per 10 unit increase in PM10, which is the pollutant which is most closely related to dust during the dust days. In a minority of the studies, the calculated change in risk is per interquartile range change in the PM10 concentration. Now, to move on to the main findings of our systematic reviews, 4 studies investigated the effects of desert dust days on respiratory mortality, and 3 of them, as you can see from the plot below, demonstrated no relationship. But 1 study from Korea demonstrated a significant association primarily on LAC3, as you can see. On the right part of the slide, you see another 5 studies that investigated the associations between PM10 increase and respiratory mortality. 3 of them demonstrated no relationship, while 2 studies, one from Spain and one from Sicily, at the bottom here, showed positive associations on LAX1 and LAX0 to 5. Here on this graph, you see the distribution of the outcomes that have been assessed for respiratory morbidity. 16 studies assessed all respiratory outcomes, 13 asthma outcomes, and COPD and pneumonia outcomes were assessed in very few studies. Now, 4 studies assessed the effect of dust days on all respiratory hospital admissions. 2 of the studies showed no association, but 2 studies, one from Kuwait and one from China, showed positive relationships on dust days with all respiratory admissions with LAX 0 and 4 respectively. 5 studies investigated associations between PM10 10-unit increase and all respiratory admissions. 3 of them showed no association, but 1 study from Israel here and 1 from Spain demonstrated positive associations at LAX 0 and 7 respectively. Another 4 studies from Korea, Greece, Australia, and Taiwan investigated associations between dust days and emergency department visits for all respiratory conditions, and all 4 of them demonstrated positive relationships at different lags, as you can see here at the bottom. 5 studies looked into the effect of dust days on asthma admissions. In 4 of these studies from Kuwait, Taiwan, Australia, and Korea, there were positive associations between the 2 at different lags. On the right, you see 1 study from Israel that investigated the association of PM10 increase per 10 units on hospital admissions for asthma and found a marginal positive effect on LAX 0 and 1. In terms of emergency department visits for asthma, 3 studies assessed the effect of dust days on them. In 2 studies, 1 from Australia and 1 from Greece, there were positive associations at LAC 0, as you can see here at the right bottom. Now, moving on to COPD, 3 studies investigated the effect of dust days on COPD hospital admissions. In 2 of the studies, 1 from Israel and 1 from Korea, on the bottom here at the left, there were positive associations at LAC 0 and 4, as you can see. In terms of the effects of dust days and PM10 on emergency department visits for COPD, there were 4 studies, and all 4 of them demonstrated positive associations between them at different lags, as you can see on the graph. Now, moving on to pneumonia hospital admissions, 1 study investigated the effect of dust days on pneumonia hospital admissions and found a marginal positive association at lags 1 and 2, while another study looked into the effects of PM10 increase per 10 units on pneumonia hospital admissions and found no relationship here on the right graph. One study from Greece assessed the emergency department visits for all respiratory infections, including pneumonia, and found a positive association of desert dust days versus non-dust days for this outcome. But when they looked into the increment of PM10 by 10 units, they found no significant effect. Finally, two studies from Japan demonstrated associations between dust days and increased respiratory symptoms as assessed by questionnaires, and also with reduced lung function at lags 0 and 1 at the top table, suggesting effects in this area. Now, with regards to the cumulative or chronic effects of desert dust, very little and weak evidence exists. I'm just going to show you data from two rather recent studies published in 2015. The first study is coming from Iran, where the authors assessed the lung function in the inhabitants of a city called Ilam in West Iran, which is burdened by quite a lot of dust. And they found that the duration of inhabitation or residence into that city was negatively associated with lung function and particularly the FEV1 value, which is associated with obstructive lung disease. However, the authors didn't have another comparison site. They just compared their values with mean reference values. And the second paper comes from China, where the authors compared the prevalence of upper and lower respiratory tract conditions between two regions, one region with a high disease, with high desert dust burden, and another one with a low desert dust burden, and found, as you can see on the table below, higher prevalence for a series of outcomes such as chronic rhinitis, chronic pharyngitis, bronchitis, emphysema, pulmonary tuberculosis, and chronic cough. However, in this study also there are weaknesses, and the authors have not adjusted for the anthropogenic pollution in these sites. So to summarize, we know now that we have substantial evidence in the last decade that there are short-term effects of desert dust on respiratory health from the epidemiological point of view. There are some positive and few null associations reported between primarily dust days and to a lesser extent for 10-unit decrease of PM10 and respiratory health. The positive associations are more consistent with emergency department visits and hospitalizations, and to a lesser extent with respiratory mortality. There is important heterogeneity in the study designs, the definitions of the desert dust events, and the adjustments for covariates, which at the time make a quantitative synthesis of this data quite difficult. Future studies should focus on cumulative and chronic effects of desert dust and the incidence of chronic diseases and the mechanisms that are implicated in these effects. Furthermore, we need to study the effects of smaller dust-sized particles and the effects of specific chemical components of desert dust on human health. And finally, we need to link these findings with possible policy decisions and prevention measures for mitigation and prevention of these effects on human health. With this, I would like to thank the collaborators that have contributed into these systematic reviews at the Medical School of the University of Cyprus, the Cyprus University of Technology, and the Harvard School of Public Health. Thank you.
Wonderful. Thanks a lot, Dr. Yalros. I have several questions, but we'll have the opportunity to discuss everything after Susanna's talk. So after Susanna's talk, we'll have a discussion section. So let me introduce the next speaker, who is Dr. Zuzanna Achilleos. Dr. Achilleos is currently a postdoctoral research associate for the Life Medea Public Health Intervention Study at Cyprus University of Technology. Her expertise lies at the intersection of atmospheric exposure assessment and public health, and her research focuses on air pollution exposure assessment and epidemiological investigations of its health effects, with a special interest in dust storms originating from Sahara and Sahel region after her doctoral thesis at the Harvard School of Public Health. Zuzanna, the floor is yours.
Thank you, Stephanie. Good afternoon and good morning, everyone. Following Professor Yalouro's presentation, I will give an overview about the cardiovascular morbidity and mortality effects of dust storms. Okay, so first, why we're doing that? As we saw it from yesterday's presentations, research on dust emissions from the desert or regions and their transportation in the atmosphere has increased over the last decades. And an important driver of this increase of research focus comes from the fact that we recognize lately the impacts of desert dust on climate, air quality, and of course, human health. Now, the need for a better understanding of how desert dust affects human health and mortality and morbidity led to the increase of multiple research and study designs and studies across the scientific community. However, the evidence that is available to us up to now is not fully conclusive, or they present different results. Now, we saw earlier about an overview of the respiratory effects. So that captures a big image, a big picture of the whole situation. But we're now focusing on the diseases of the circulatory system. And when we refer to the circulatory system diseases, we refer to both the cerebrovascular and cardiovascular diseases. With cerebrovascular, we refer to the disorders and the diseases that affect the blood vessels in the brain. For example, stroke is one of that. And cardiovascular diseases refers to the diseases and disorders that affect the blood vessels in the heart, such as myocardial infarction, heart failure, arrhythmias, hypertension, atherosclerosis. However, we tend to refer to both of them as cardiovascular diseases. So as I follow and move on with this presentation, when I refer to cardiovascular, most of the times it refers to both of these, unless there is a clear description of the two. Professor Yalouros mentioned about the systematic review that we conducted in July 2020, and that was in order to find all the evidence on epidemiological studies that investigate the association between desert dust and health effects. We found 69 epidemiological studies, and 39 of them that were published until July 2020 addressed the question, does desert dust cause any acute cardiovascular effects? The design that they used these studies was mostly either time series or case crossover studies. We found 17 studies that looked the association between cardiovascular mortality and desert dust. 21 studies looked at the morbidity effects, and one study examined both the mortality and morbidity effect of desert dust. Here, this graph, I have a number of studies by publication year. Dark red refers to the mortality studies, and the light red is the morbidity studies. So as we can see, the publications, first publication on cardiovascular effect and desert dust, the first one was published in 2005. But the increase in the interest among the scientific community about that was more pronounced after 2012. Mortality studies were mostly published in 2011 and 12, and since then only 7 studies were published until now. This graph shows a geographical distribution of the studies that is available on cardiovascular effects and desert dust up to now. So most of them examine the Asian dust, meaning the dust that's coming from the Gobi Desert that is mostly in China and Mongolia. There were 22 studies out of our 39 studies that they were based on Asian dust. These were based mostly on China, Japan, South Korea, and Taiwan. And most of the morbidity studies were from these countries as well. Second, more often, studies were found in Europe, specifically Cyprus, Greece, Italy, and Spain. Greece, Italy, and Spain are mostly affected, as we said yesterday, from the Sahara Desert, where Cyprus is affected from both the Arabian Peninsula Desert and the Sahara Desert. However, from Middle East, we only found 3 studies, one from Kuwait for mortality effects, and another 2 for morbidity, one from Iran and one from Israel. 2 studies were identified from Australia desert. Now let's first see the evidence from epidemiological studies that associate desert dust and cardiovascular mortality. But before I show you an overview of that, I would like to first describe a little bit about how the dust is used as an exposure metric in the models. This is important so we can understand later on the different outcomes. So how desert dust impact human health can be studied in different ways. And actually, a recent paper from Tobias and Stafokia, they describe 5 different methodologies or different ways to answer this question about dust and human health. And they talk about different 5 models. Here I'll present you 3, which are the most common and the ones that we're gonna see later on. So when we study the effect of dust on human health, first, of course, we need to identify the dust days over that time period of our study period. And then we usually create an indicator variable we name as dust, and that indicator variable takes the value 0 for non-dust days and value equals to 1 for dust days. Having that in the model, though, in our model, which we have dust as the binary, and then other confounders such as time, day of the week, or meteorological variables, we can assess if the mortality is higher on dust days compared to non-dust days. And this way, we treat dust as a risk factor. Now, another most common way to assess dust and human health is also include the PM. And in one way to do that is having dust as effect modifier, where in the model, besides the dust indicator variable, we add the linear, most of the time, association of PM10 and an interaction effect or interaction term of dust and PM10. With this way, we can see what is the association of PM10 during dust days with the mortality or the morbidity. Also, the association of PM10 during non-dust days, but the interaction effect or the interaction term, it will answer whether the association between daily PM10 and mortality is different on dust versus non-dust days. Now, the other way that dust can be treated is having dust exposure as a continuous metric. This is not something that we find very common in literature. We found mostly from European studies and from Asian studies. So in Europe, there is a way to quantify the desert dust contributions to PM10, and the EU has also a reference method. What they do, they take the time series of data of PM levels, they remove the dust days, and they get the 30-day moving 40th percentile of the daily PM10 for each day of the series. And that represents the expected PM10 levels. In order to assess or estimate the desert PM10, meaning the contribution of the desert dust to PM10, they get the difference between the observed and the expected PM10 concentration during dust days. Now, assuming that the load of particles during dust days is similar or is distributed equally across the area, the non-desert PM10 contribution, it can be estimated by getting the difference between PM10 levels and the desert PM10. Now, how this is treated usually, so it's assumed that the desert PM10 and non-desert PM10 is associated with mortality, but independently. So what they do, they put both of these two continuous variables in the same model. Now, Asian studies are doing something different. Actually, they're using Asian dust as a continuous metric, and they're using LiDAR observations. LiDAR is a remote sensing technology that measures Asian dust aerosols with a size of less than 10 micrometers. Now, by measuring the laser reflection from the ground, it can distinguish the non-spherical mineral dust particles from the spherical non-mineral dust particles from anthropogenic sources. And usually they can add this Asian dust variable in the model to assess the association between the Asian dust, with the health effects. I hope I made it as simple as I could. Okay, so having this in mind, we identified 11 studies that they examined whether cardiovascular mortality was higher on dust days compared to non-dust days. 4 out of them, they show a significant and a positive association, meaning more mortality on dust days. 3 out of these 4 were based in China, South Korea, and Taiwan. And they all found a positive association with higher effects among elderly. One from Europe, and specifically in Athens, that also found an increase during dust days and among the elderly. Now, including PM as a metric of desert dust in the model, we found 7 studies that examine whether PM during desert dust is associated with cardiovascular mortality. And 5 of them also examine if the association between daily PM and cardiovascular mortality is different on dust versus non-dust days. Actually, all of these 7 studies found a significant association between PM levels during desert dust and cardiovascular mortality. One of them was around this region, based in Cyprus, where they found an 2.4% increase in daily cardiovascular mortality for every 10 microgram per cubic meter increase in PM10 on dust days at lag 0. However, there was no association during non-dust days between PM10 and cardiovascular mortality. The rest 6 studies, they're mostly from Europe, Madrid, Spain, Barcelona, Rome, Athens, and only one was from Asia countries, from Seoul. These studies they examined different PM metrics. So Madrid looked at PM10 and they found a positive association for the general and the elderly population. Barcelona, they looked both the fine fractions, so for PM between 1 and 2.5 micrometers, but also for coarse particles. One study in Italy also examined the coarse particles and for PM10. And in Greece, they didn't find any association between PM10 and mortality during dust, but the effects were higher during non-desert dust days for the elderly. And the one from Seoul, they found association between PM2.5 and mortality for days, Asian dust days mixed with smog. Now, getting dust as a continuous variable, we only had 3 studies. 2 of them were from Europe, where they had the desert PM10 and the non-desert PM10 in the same model. They found an association between the desert PM10 and cardiovascular mortality. The study in Italy was based in Italy. They found lower effects for non-desert PM10, and the multi-city from Greece, Italy, and Spain found no significant effect for non-desert PM10. In Japan, when they used Asian dust as continuous variable, they found association between Asian dust with heart disease, ischemic heart disease, and arrhythmia, cardiovascular mortality. So let's now move on to see the association between desert dust and cardiovascular morbidity. As I mentioned in the beginning, we found 22 studies that they looked morbidity and cardiovascular. And only 3 of them, they examined the association between desert dust and cardiovascular diseases in the Middle Eastern region. One of them was based in Iran, where they found a significant increase in hospital admissions for total cardiovascular, coronary artery disease, and ischemic heart disease with a lag of 5 days. And that was an association with PM10 levels during dusty days. A second one was based in Israel, where they looked at the hospitalization due to acute coronary syndrome, and they found higher hospitalization during dust storm days. They also found that hospitalization was significantly associated with PM10 during dust days, with a delayed response of 1 day. The effect size for the dust exposure association was larger for older, female, and Bedouin patients as well. And the third was based in Cyprus, in Nicosia, where they looked at the cardiovascular admissions. And they compared dust with non-dust days, where it was almost significant increase of cardiovascular admissions when they took all identified dust days. They found a 10.4% increase. However, when they restricted their analysis, looking at the highest quartile of PM10 in days, when they looked at the days with the highest fourth quartile, they found a 7.1% increase in the cardiovascular admissions, and that was statistically significant. So the remaining 19 studies on morbidity was mostly based on Asia dust. And for the remaining, I categorized all the cardiovascular morbidity in 3 different categories. So first, let's see the association between desert dust and total cardiovascular diseases. We identified 6 studies. Out of 4 of them found a significant association or increase in the admissions or in the hospital admissions. 3 of them were based in Taiwan, Japan, and China, and 1 was in Europe, in Rome, Italy. Here they looked this association using PM. So they looked at the association between hospital admissions and per 10 micrograms per cubic meter increase in PM. Different PM metrics were used. So we had the PM 2.5, suspended particulate matter, coarse particles for 1, and for 2 actually. Now, looking at the acute coronary symptoms of the ischemic heart disease included acute myocardial infarction, we found 8 studies that they examined this association. 6 of them found significant association between Asian dust. So all of them were based, or they looked at the Asian dust effect. And they found association between the Asian dust effect and admissions for acute myocardial infarction and ischemic heart disease. Third group includes desert dust and cerebrovascular disease, included stroke. From that, 5 studies were found a significant association about cerebrovascular disease. 4 of them again were based on Asian dust from Japan, Taiwan. Most of them, they looked dust versus not dust days. One was based in Italy, where they found an increase in the cerebrovascular hospital admission, which is associated with PM10 levels during dust days. Asian dust was also associated with other, or was examined with other circulatory diseases. A significant association between dust events with a lack of 3 days and hypertension in males was found in China. Cardiac arrest was examined in Japan, and heart failure in Taiwan and China, but no significant association was found. And overall, with the evidence that have been shown so far, cardiovascular mortality and morbidity is associated with desert dust events. And most of the studies that they looked at PM desert and effects were all in the same conclusion. Of course, they were different in the different PM metrics. So if they look PM10, if they look coarse particles, and then different lags. Most of them found that elderly and males are in higher risk. However, most of them we saw that they were based in Asian countries or looking at the Asian dust, but little information on the association between desert dust and cardiovascular effects is available for the Middle Eastern countries. Standardization of epidemiological studies is needed, though, in order to make the short-term estimate of desert dust more comparable between different regions and studies, and especially how dust is treated as an exposure metric, exposure variable in different studies using different models. That makes it even harder. We didn't find any studies that looked at the longer term effects of desert dust and cardiovascular effect. So that's something that can be more studied in the near future. Thank you, and special thanks, of course, to the team of the research group of Live Media that conducted this systematic review. Thank you.
Great, thanks a lot, Susanna. And now it's time to start our discussion session. We have several questions lined up for our presenters. So the first question is from Professor Koutrakis. I think it's towards Dr. Yalouros. Is it possible that the dust from different deserts have different toxicities? Also, housing and comorbidities may vary by region. So how do you think these factors could affect the results of the studies and what you see when you try to summarize the evidence?
Yes, it is possible, although we don't have data to verify this notion. But it is quite likely that the trajectories of the dust before reaching a site would pick up different toxicants during their course, which may vary from case to case. And in this way, at least from the theoretical point of view, the effects might be different. And that is why in my summary sort of notes, I sort of stress the need to have newer studies that will look into the elemental composition of this dust, and of course, perhaps in other constituents of the dust that would sort of help us to assess this question.
Petros, do you have any other comments on that?
No, also comorbidities, like, in Greece there are smokers, so that also can play a factor.
Yeah, the composition of these populations is quite different. Professor Weiskopf is asking, I guess this goes to Susanna. It seems to me that it's tricky to look at the interaction between dust day and PM, because isn't the PM level at a very different level on dust days? And how much overlap is there in the PM levels on dust days and the non-dust days?
Of course, on dust days, you have the PM levels that the particles that originate from other anthropogenic sources. But what we're trying to see with the interaction is there is any difference between the PM levels on that days with dust versus non-dust, which during dust days in most places, the contribution is mostly from the dust, the desert dust.
If I may add to this, Susanna and Stefania, in the studies that have been published so far, about 1/4 of them have also the comparisons of the estimates of the effects of PM10 on dust days and non-dust days. And in most of the studies, including our study in Cyprus with Nikos Mitleton back in 2008, the effect is of the same magnitude. Although this is something that needs to be perhaps analyzed in bigger numbers, but at least the first indication is that the evidence for the magnitude of the effect is comparable.
Going back to Mark, oh, sorry, Susanna, yes.
Yeah, I just wanted to add on that it also depends on what PM metric you're using. So as far as I have seen, when using coarse particles, is usually higher effect during desert dust days. But when you look PM10 or PM2.5, that may change. So you may end up having a higher effect during non-dust days. So that's also another factor.
Yeah, this conversation reminds me of Dr. Weiskopf's question yesterday about what was the definition of dust days in the studies. Was it uniform? Were there differences? Because yesterday, Dr. Al-Hemmoud said that they use the visibility definition. So was that used frequently in the health studies?
It is. So the visibility is based on the World Meteorological Organization, and most of the Middle Eastern countries are using that in order to identify dust. I would say that every region is different. So from the Asian countries, I found different definitions, and that's something that differs across studies, that even they look human health effects or they look exposure. So that's another, let's say, issue that brings variability, and it's difficult to compare results across studies and across regions as well.
If I may add to this, this underlies also the need for new studies that would sort of assess the trends of the phenomenon, but also the effects of the phenomenon on health that are multi-country or multi-center, and use the same methodology in defining what is a desert dust event and so on. We have serious methodological issue in all this literature that has been published so far, because it's fragmented into one center or into one country, and the results are not comparable because of all these issues. And I have to congratulate Susanna, because she published last year one of the first studies that used the same methodologies in assessing the desert dust events and their trends in the region of Eastern Mediterranean by combining data from Greece, Cyprus, and Israel.
Wonderful. Dr. Weiskopf, I see your hand is raised.
Yes, yes, thank you. So thank you very much for those responses. That's interesting. Oh, start my video, sure. So thanks for those responses. I just wanted to lay out sort of one of the things I was thinking, and your 2 points relate to this is that I guess I would have thought that it's quite possible that if one is looking at the effect of PM, we see this, for example, in children's blood lead on cognitive effects, that there's a steeper dose response at the lower levels. And as you get higher, it flattens out. And that could be for many reasons. It could be for biological ones. It could be for behavioral modification. You go indoors so you don't experience it. So my concern with looking, stratifying kind of by dust days is that in the dust days, if everything is so high, you may actually have a flat dose response because you're at such a high level already. But I think Dr. Yaloris was saying that you found about the same effect. So that was what's behind my question. And any comments you might have on that would be great.
Again, this goes back to what is the definition of a dust storm. And in the old sort of studies definitions, it was just to exceed a certain threshold of PM10 concentrations and so on. But if you look into more sources of information, and Susanna can elaborate on this more because she did this study, you can even detect days with lower concentrations that have the dust or the particles originate from deserts and dust. And this can sort of help us to assess their effects in the lower range when there are particles from the deserts. Susanna, maybe you can elaborate more on this if you want.
Yes, I understand let's say the concern about the shape of the relationship. So far, what I have seen when people are trying to see the non-linear, or let's say see if the PM10 is different affecting the health studies, the health effects during dust and non-dust days. Usually during dust and PM10 dust is more like a linear relationship than going to a more like a benchmark.
Thank you.
Yeah.
Great, thanks a lot. So the next question is from Evans Chingyoko. What are the effects of dust storms on mental health and the endocrine system? Have cortisol levels been measured during such storms? This is directed, I guess it says the first presenter, to Dr. Yalouros.
Well, there is no data that I'm aware of. I'm not sure if there is any. Just search now the PubMed, and there's just one publication from Turkey of 2016 that look into the quality of life in allergic adults during desert dust events, and they use the SF36 questionnaire, and one of the scales there is on mental health, and it was significantly reduced. But that's the only reference that I can come up with in PubMed at the moment. And I don't know of any studies that measure serum cortisol, plasma cortisol during the events. I don't know if Victor is there.
Yeah.
If he wants to add something.
Yeah, so this is Victor Noak from Israel. Actually, I'm aware of at least 2 studies done in Israel. One of our studies was looking on suicidal attempts as a function of heat and dust. While we didn't see any association with the dust, we did see an association with the heat, especially during the summer. The second study that I am aware of also was done in Israel, not by my group, but was looking on admission due to the acute psychosis as a function of heat. And also there they saw an effect of the heat waves on the admissions. Regarding cortisol, we don't have such an information just because it's very difficult to run, but we do know that the PM exposure is associated with at least insulin resistance that we have shown in some of our studies around lipids response to the dust storms and blood sugar response to the dust storms.
Great, Dr. Weisskopf.
Yeah, I was just going to quickly add that not related to the dust storms, but there's a variety of work on PM 2.5 and maybe 10, although it tends to be the lower fraction that we see this, including some of our own in the Nurses' Health Study on mental health symptoms and PM levels, but not specifically related to dust storms. These would be, of course, much lower levels. But there is not just ours, but other evidence as well on that.
Great. And one last question before we go to our break. Gordon Honeyman asks Susanna that often clothing is used as a protective measure for desert dust. Do you feel that that might affect the exposure outcome association, the way that people are protected from, they're trying to protect themselves from the desert dust?
Yeah, I think every personal protection measure will affect that. From the regions that we did studies, at least, I don't know in the Middle East how people behave, but here at least there's nothing much protection. Of course, I can imagine staying indoors or wearing a mask, it will reduce the outcome, of course. Yes, definitely.
Wonderful, thanks a lot. I think it's time to go to a break. It will be a 10-minute break. We're gonna come back in 9:55. I would like to thank all the presenters for the excellent presentations, and I'm looking forward to the next one. So see you in 10 minutes. So it's 9:55. I think it's time to resume again. So it's my pleasure to introduce Professor Yarlos again, who is going to present us the pediatric effects of air pollution. Dr. Yarlos, the floor is yours.
Thank you, Stefania. Right. So in this second talk, I'm going to present an overview of the data on the pediatric effects of air pollution in general. And here the data are profoundly larger and richer than those in the case of desert dust health effects. So I'm going to focus on meta-analysis here, primarily in the area of respiratory outcomes, both cumulative and chronic effects, but also short-term effects of air pollution or respiratory outcomes. Also, I'm going to talk on central nervous system outcomes, leukemias, and congenital heart disease. As you all know, children have narrow airways, and they breathe faster and deeper in relation to adults for their body weight. And this exposes them to higher levels of airborne pollution for their size. So a big chunk of the outcomes of interest have to do with the respiratory system. So I'm going to talk specifically on the cumulative or chronic effects of air pollution on the development of asthma and wheeze, allergic sensitization, allergic rhinitis, conjunctivitis, and eczema, lung function, and also talk on the short-term effects of asthma exacerbations, pneumonia, otitis, and respiratory mortality. Let's just start by traffic-related air pollution trap, which is the most well-studied type of air pollution in relation to children's health. This meta-analysis, which was published in 2017, reviewed 42 studies and use primarily nitrogen dioxide, NO2, as the most commonly assessed pollutant and the surrogate marker of TRAP. They estimated most of the studies the exposure at the residential address of the children, and they usually assessed it in the first year of life, while a few studies assessed different windows or multiple exposure windows. And of course, again, in this meta-analysis, there was quite a lot of variability in the asthma definitions and the adjustments for confounders. So in this big meta-analysis, there was evidence for a positive significant association of NO2 black carbon, PM2.5, and PM10 with the development of asthma and wheezing. One interesting question is which type of childhood asthma is related to TRAP? As you probably know, the asthma in the preschool age is characterized by different types as transient wheezing or asthma, persistent or late onset asthma and wheezing. So this publication here in 2008 reviewed 7 articles with this question, and they found that the TRAP exposure was associated with the transient and persistent type of asthma or wheezing, while there was little evidence of association between the late onset asthma or wheezing. Another important question has to do with whether the organic and inorganic air pollutants that are related to TRAP, to traffic-related pollution, have the same effect on the development of childhood asthma. And this was the focus of this meta-analysis here, which reviewed 27 studies and demonstrated that both types of pollutants had significant associations with childhood asthma, and namely PM2.5, NO2, benzene, and total VOCs, with the inorganic constituents of TRAF pollution, PM2.5 and NO2, having significantly higher effect in Asia than in Europe and North America. Another very important question that was actually asked yesterday by one person in the audience is how much of the childhood asthma incidence is related to air pollution, and in this case, TRAP. This was the focus of this publication in 2019 in Lancet Planet Health, that estimated the NO2 attributable burden of asthma incidence in children in 194 countries. And the authors estimated that 4 million cases of new cases of asthma annually can be attributed to NO2 pollution, with the 2/3 of them occurring in the urban areas. And they also estimated the global incidence of childhood asthma that is attributed to NO2 to be at 13% of the total. Another interesting finding of this study is that most of the pediatric asthma cases incidence attributed to NO2 exposure seem to be occurring in areas where the annual average NO2 concentrations were below the WHO guideline at 21 ppbs. A similar study from the US examined the asthma cases that are attributed to TRAP. And here they used the NO2, PM2.5, and PM10 as surrogate markers of TRAP, and found that the asthma incident cases in the country in 2000 were ranging from 27 to 42% of the total, while in 2010 they were ranging between 18 and 36% of the total. Again, here the air pollution contribution to new cases was stronger in urban areas than in areas with lower socioeconomic status. Now, 2 meta-analyses looked into the impact of prenatal exposure to air pollution and development of childhood wheezing and asthma in the first years of life. The first meta-analysis of 18 studies demonstrated a significant association of NO2 exposure with childhood wheeze and NO2 and PM10 exposures to the diagnosis of childhood asthma. The second meta-analysis reviewed 9 studies and assessed the prenatal exposure to PM2.5 and demonstrated significant associations with childhood asthma and wheezing before the age of 3 years. And that was more profound in the developed countries. Two meta-analyses examine the effects of air pollution on the development of allergic sensitization. The first meta-analysis reviewed 19 articles from European and American bird cohorts. For indoor aeroallergens, they found no association of air pollutants with sensitization to them. But in the case of sensitization to outdoor aeroallergens, there was a significant association with exposure to PM2.5. Whereas for sensitization to food allergens, at the age of 4 years, there was a significant association with increased NO2 exposure, while the association was weakened at the age of 8 years. The second meta-analysis reviewed data from 5 European bird cohorts and found no association between overall air pollution exposure and sensitization to any common allergens. Two meta-analyses reviewed the effects of air pollution on rhinitis, conjunctivitis, and eczema. The first meta-analysis looked specifically on childhood allergic rhinitis. It reviewed 13 studies and found significant associations of exposure to NO2, SO2, PM10, and PM2.5 with childhood allergic rhinitis. The second meta-analysis reviewed data from 5 European bird cohorts and found no association between air pollution and rhinoconjunctivitis and eczema. Moving on to lung function, 2 meta-analyses reviewed data between air pollution exposure and lung function. The first meta-analysis reviewed 11 articles from 7 cities in China and demonstrated that lung function was significantly lower in areas with heavy ambient air pollution. And there was a particular effect of SO2 and particulate matter on reductions in FVC and FEV1 and in reductions of mid-expiratory flows in relation to NOxes. And here the estimates were stronger in girls in comparison to boys. The second meta-analysis synthesized data from 5 European bird cohorts and demonstrated small decreases in lung function in terms of FEV1 for NOxes and PM2.5. Now, moving on to the short-term effects of air pollution and asthma morbidity. 2 meta-analyses and 1 multi-center study examine these effects. The first study is gathering data from 4 large European cities and looked into the emergency room visits for asthma and found significant associations with exposure to SO2 and NO2. The second study is a meta-analysis of 87 studies that looked into the excess risk for hospital admissions for asthma and found stronger associations in children rather than in adults. And these were significant for exposure to NO2, SO2, PM10, and PM2.5. And the third meta-analysis synthesized data from 22 studies that were examining emergency department visits, emergency calls, or hospitalizations for asthma exacerbations in children, and found significant associations with exposure to NO2, SO2, and PM2.5. One meta-analysis and 1 multi-center study examine effects of air pollution on lower respiratory tract infections. The first is a systematic review meta-analysis of 4 eligible studies that found significant associations with PM2.5 exposure. The second study looked into the associations of ozone with emergency department visits in the US and found significant associations in Atlanta and Dallas, but not so much in St. Louis. And again, here the estimates were stronger in low socioeconomic status areas. Two meta-analyses and two studies on multi-cohort combined data looked into the short-term effects of air pollution on pneumonia and otitis media. The first meta-analysis of 17 studies looked into the hospitalization of children due to pneumonia and found that there was an excess risk for hospitalization per 10 unit increase in the concentrations of PM10, PM2.5, SO2, ozone, and NO2. The second study investigated associations between air pollution and parent-reported physician-diagnosed pneumonia in 10 European birth cohorts and found statistically significant associations with NO2 and PM10 exposures. This third study explored the association between 8 elements that are related to particulate matter with parental reports of physician-diagnosed pneumonia in 7 European birth cohorts in almost 16,000 children, and found only weak associations of zinc derived from PM10 with pneumonia. And finally, this meta-analysis of 12 studies looked into the associations of otitis media with air pollution and found significant associations with increasing concentrations of PM2.5 and PM10. In terms of respiratory mortality, there are only very few studies in children. This is one of the most prominent ones. And it looked into the effects of air pollution on infant and children's respiratory mortality in 4 large Latin American cities. It followed a time series design and calculated that for every 10 unit increase in the PM10 concentration, there was significant increase in the respiratory mortality, and that was more profound in the under 5-year-olds and in the case of lower respiratory tract infections. Now, to move on into the central nervous system effects, 2 meta-analyses and 1 study from multi-cohort combined data examined the effects on autism. The first meta-analysis of 23 studies assessed exposure to airborne pollutants prenatally and autism spectrum disorder and found significant associations with increasing PM10 and PM2.5 exposures. The second meta-analysis of 25 studies on maternal exposure to outdoor air pollution by trimester of pregnancy and AESD in children found significant associations with increasing concentrations of PM2.5 and NO2 with 2 different approaches in meta-analysis, the frequentist and the Bayesian meta-analysis. And finally, this last study looked into the effects of air pollution exposure during pregnancy and childhood autistic traits at the age of 4 and 10 years of age in 4 European cohorts of more than 8,000 children and found no associations between the 2. Now moving on to psychomotor outcomes, 1 meta-analysis and 5 studies on multi-cohort combined data examined this association. A pile of 4 multi-cohort data studies found significant associations of air pollution exposure, especially motorized traffic pollutants, with delayed psychomotor development in childhood. Another study that synthesized data from 8 European cohorts found no association between air pollution exposure and depressive, anxiety, and aggressive symptoms in children. And finally, a meta-analysis of 10 studies looked into the effects of increasing NO2 concentrations during pregnancy and demonstrated decreases in the global and fine psychomotor development of children. The authors of this study tried to associate other indices of mental development, but there wasn't enough data to associate them with attention deficits, IQ, and behavioral issues. With regards to leukemia, 4 meta-analyses explored the association of air pollution with hematological malignancies. The first meta-analysis found positive association between residential traffic exposure as assessed in 7 studies, and that was significant when they assessed the postnatal exposure window, whereas when they looked into prenatal exposure, this was not significant. The second meta-analysis of 26 studies showed that NO2 exposure was significantly associated with acute lymphoblastic leukemia, while exposure to benzene was associated with acute myeloid leukemia. And again, here the estimates were higher when the exposure was assessed in the postnatal period compared to exposures in the prenatal period. The third meta-analysis of 15 studies examined exposure to traffic density or traffic-related air pollution and found that there was a significantly increased risk for acute myeloid pneumonia, leukemia, and to a lesser extent for acute lymphoblastic leukemia. And finally, a fourth meta-analysis of 29 studies found little evidence between for association between traffic indicators and leukemias. But when they specifically looked into benzene exposure, there was a positive association with leukemia, particularly for acute myeloid leukemia in children under 6 years of age, while NO2 showed little association, which was only significant at the very highest level. Now, moving on to the congenital heart defects, 2 meta-analyses investigated this association. The first meta-analysis of 5 studies looked into maternal exposure to PM2.5 during the first trimester of pregnancy and found no association with any type of congenital heart defect, while the second meta-analysis of 26 studies assessed maternal air pollution exposure and found that high carbon monoxide exposure was associated with phallus tetralogy. High exposure to PM10 and ozone was associated with increased risk for atrial septal defects, and high NO2 exposure was associated with coarctation of the aorta. So to conclude, it appears that there is extensive body of knowledge in the last decades in regards to associations between air pollution and children's health, both from the epidemiological but also from the mechanistic point of view. Overall, there are many positive and few null associations for the cumulative effects of air pollution on the development of pediatric respiratory disease, and as well as for short-term effects for respiratory outcomes to do with hospitalization and emergency department visits for outcomes such as total respiratory, asthma, and lower respiratory tract infections and pneumonia. The positive relationships are more profound and more frequently reported between traffic-related air pollution or pollutants such as NO2, PM10, and PM2.5. More attention should be paid to the associations between air pollution and other pediatric diseases, such as those affecting the nervous system and hematological malignancies. And of course, future studies should focus on the mechanisms that are implicated in the development of chronic diseases by air pollution or exposure in various systems, as we mentioned earlier. And finally, more intervention studies are needed to reduce children exposure to air pollution and link the finding with possible policy decisions and prevention measures. And with this, I would like to thank you, and I'm open to questions.
Great, thank you so much, Dr. Yalouros. We are a bit behind on schedule, so unless there is an outstanding question, which I do not see, we'll move on to the next presentation, which is going to be, I'm going to give the next presentation. So as Petros said in the beginning of the webinar, I am Stefania Papatheodorou. I am a lecturer at the Department of Epidemiology at the T.H. Chan School of Public Health. I am also a trained obstetrician and gynecologist, and I have been working on the effects of health of the exposure of air pollution to perinatal effects. Panagiotis, can you answer? Yes, wonderful. So I guess you can see my slides, right?
Yes.
Wonderful, thank you. So first of all, thank you for this opportunity to give this presentation. And what I would like to do is to discuss a bit about the effects of air pollution on perinatal outcomes, not in a worldwide context, but on a regional context, on the MENA region, and see what evidence we have in this region, whether there are problems or we should be looking at different things, and how the results and everything that we have from this area compares to the world. So I'm going to briefly present some recent pollution data from the region and how they compare with the rest of the world. I'm going to discuss about the prevalence of common pregnancy, adverse pregnancy outcomes in the region, such as preterm birth and gestational diabetes, and whether there is a problem in this region and we should be looking at the effects of environmental exposures or not. I'm going to provide a brief summary of evidence of the association between air pollution and pregnancy outcomes from this specific region, and identify the gaps in knowledge and some recommendations for the future research. I think you are seeing my presenter view, which should not happen. So let me just stop sharing. So now you can see my slides only, right?
Yeah,
It's clear, very clear.
Great, great, thanks so much. So as I was saying, my goal is to present a brief overview of the data we have from this region and identify the gaps in knowledge and some recommendations for future research. So this is a map of the world regarding air pollution. So here we see, here we can see the map of the world, as I said, and we see how the PM2.5 levels look like in the whole world. So we can see areas that are very clean, and we can see areas that are a bit problematic. And this involves this region that we care so much about. So we see that the pollution levels in general are high in the region compared to the rest of the world. And some of the 10 most polluted countries in the world do belong in this region. So in terms of pollution and in terms of what we have as air pollution exposures, this area has pretty high exposures. There are places that are putting efforts towards reducing the PM2.5 levels, and they have been successful. But there are places that instead of reducing the emissions, they are increasing the use of coal and other pathways through which PM2.5 levels increase. So this is something that we should be definitely looking about, and we heard a lot about this yesterday in the previous talks. So this is a slide that shows the annual trends in the global burden of disease superregions and in general in some countries. So in the left-hand side of the screen, we see the trends from 2010 until 2009. And we see while some countries have substantial decreases and some global burden of disease areas have substantial decreases in air pollution, there are others, including Sub-Saharan Africa, North Africa, and the Middle East, that actually can experience increases in the levels of air pollution throughout the last years. So this is something that is worrisome in terms of the health effects of these exposures. As I mentioned before, there are countries that experience increases in exposure of PM2.5 instead of experiencing decreases in exposures of PM2.5. And this is something that we should be very worried about, given all the awareness that is provided regarding the health effects of air pollution. Now, pregnant women are specifically vulnerable to the effects of air pollution for many reasons. For the changes in physiology, because the the rate of breathing increases during pregnancy, and because of the other physiological changes that happen in all the 3 trimesters. So once air pollution gets inhaled, it can stay in the lungs and manifest oxidative stress and systemic inflammation, or it can translocate into the circulation. And we have found evidence that certain elements can reach the placenta, such as blood carbon, such as polonium. So we actually have direct evidence on how the fetus can be affected by air pollution, or translocate in other organs and manifest several effects. For example, it has been associated with endothelial dysfunction and cardiovascular inflammation. It has been associated with increased beta cell stress and beta cell dysfunction, which can lead to insulin resistance or even gestational diabetes. It can increase adipose tissue inflammation and altered adipokines, and adipokines are molecules that play a huge role in the metabolic profile of pregnant women. It can decrease the glucose uptake in the muscles and increase the insulin resistance, or even alter the gut microbiota and gut permeability in glucose and other substances. So we see it can have many effects during pregnancy, and these are the mechanisms through which several adverse outcomes can be manifested, like gestational hypertension, gestational diabetes, or preterm birth through the systemic inflammation. There are some associations that have been established throughout the years. So there have been some associations that, given the evidence that have been produced throughout the last decades, we know that there are effects like for preterm birth and low birth weight. We do have evidence for gestational diabetes. We do have evidence for hypertensive disorders of pregnancy, but the debate lies on which trimester is the most susceptible. And even we have data for epigenetic changes that can be transferred to next generations. Preterm birth is one of the main problems in obstetrics. No matter how many advances we have in prenatal care or in pharmaceutical interventions or other clinical interventions, preterm birth has been stable in the range of 10%. So the worldwide prevalence of preterm birth is 10%. And why we care about preterm birth so much? Well, we do because it's the main cause of death in children under 5 years of age, and it causes significant morbidity as well. So this is something that if we can identify any modifiable risk factors, that would make a big difference in the prevalence of preterm birth. So here is a map that shows the preterm birth rate worldwide again. We can see that, again, most of the countries have a prevalence of a rate of around 10%. There are countries that have more, like 10 to 14%. So we see that this region, again, is on the high end of the prevalence of the preterm birth. So we see even here, Jordan has a prevalence, estimated prevalence of 15 to 20%, which is huge. So as you understand, any modifiable risk factors for preterm birth identification and the regulation of these factors would be of great importance. In 2017, there was a paper published about a global assessment of preterm birth and air pollution. So here we see 2 graphs, again, maps of the world, showing how the area compares to the rest of the world. The researchers calculated the percentage of total preterm births associated with PM2.5 levels in 2010 using a low concentration cutoff of 4.3 micrograms per cubic meter, or 10 micrograms per cubic meter. So we can see that these areas are heavily affected by PM 2.5. So we have a large percentage of preterm births attributed to air pollution in these areas, much less than other areas in the world. We see the same in China, of course, but we see that this area has a very high percent of preterm births attributed to PM 2.5. So we can understand that the regulation of such a modifiable risk factor could make a huge difference, and it could change things tremendously for the outcomes of women and children in this area. Gestational diabetes, we heard yesterday that there is a big problem in the area with diabetes in general and gestational diabetes more specifically. Here is a summary that was published in 2019 of studies that have been published throughout the years. And we can see that the country with the highest prevalence was Egypt with the very high number of 24.2, Saudi Arabia with 17.6%, and Morocco with 15.6%. Now you see that this summary has a lot of issues. The estimates are all over the place. That can be due to methodological differences between the studies or to factors that make the populations different, like the composition regarding age or higher BMI in these countries. So evidence from the region, what do we know about the association between air pollutants and adverse pregnancy outcomes in this region? There is only one systematic review of the effects that was published in 2016, so it has been like 5 years already. 12 studies have been identified. We have 3 studies from Iran, 3 from Jordan, and 3 from Saudi Arabia, 1 from Palestine, 1 from Iraq, and 1 from Pakistan. Most studies, in terms of design, most studies were retrospective cohorts. 4 were cross-sectional studies and 2 were case control studies. The sample size of these studies ranged from 223 to around 8,500 births, and the time frame was from 2004 until 2012. In terms of air pollution data, 7 studies examined secondhand smoke, which is very prevalent in these areas. So that's a really important issue, but for indoor air quality. 3 studies examined PM10, 3 studies examined gaseous air pollutants, 2 studies examined indoor wood fuel smoke, and only 1 study examined polycyclic aromatic hydrocarbons. Now, the way that these data were obtained was not the best. So exposure to secondhand smoke and wood fuel smoke was self-reported. Exposure to outdoor pollutants, including gaseous pollutants and particulate matter, was assigned based on data from the nearest central site monitoring station without any other temporal or spatial resolution. And polycyclic aromatic hydrocarbons were assessed using blood tests. So very briefly, regarding low birth weight and outdoor pollutants, a study from Iran with 225 women within 5 kilometers from the monitoring station. They looked at different pollutants. Carbon monoxide exposure was the only significant risk factor for low birth weight, with an impressive odds ratio of 2. And during the second trimester, this association was even stronger. Another study from Iran, including around 5,000 pregnancies, they used this categorical pollutant standards index to estimate exposure during the entire pregnancy, which is an index that includes many pollutants together. From 2014, they included PM 2.5 as well. It was not included in the previous years. And they found no association between this metric and low birth weight in all exposure periods. So that makes us think that these null associations may or may not be true, given the errors in the exposure assessment or the way that health data were obtained. So we need to think about the problems of these studies. Birth weight and indoor biomass fuel smoke, studies from Pakistan showed an 82-gram reduction in birth weight in infants born to natural gas users rather than houses that used the fuel smoke. In Palestine, there was a significant decrease of 309 grams in infants born to women who were exposed to wood fuel smoke rather than the non-exposed group. Both studies showed associations with exposure to indoor quality and low birth weight. Regarding preterm birth, very, very sparse evidence. only one prospective cohort study from Iran examined the effect of outdoor pollutants and preterm birth. Again, they use this index, the pollutant standards index, to estimate the exposures during entire pregnancy and trimester-specific exposures. Preterm birth was associated during the entire pregnancy significantly with exposure to the PSI. Spontaneous abortion, there is some evidence there. Again, from Iran, a case control study using data from outdoor pollutants, the pollutants that were mentioned before from a fixed site. Exposure to carbon monoxide showed the strongest association again. Exposure to NO2, PM10, and ozone showed weak but statistically significant associations, marginal for PM10, a bit stronger for NO2 and ozone. Since then, there were some studies published that had methodological advances. There was a study published regarding air pollution and the risk of stillbirth. It was a time series study between March 2015 and March 2018, looked at several pollutants and the risk of stillbirth, and they found that a 5 parts per cubic meter, 5 parts per billion increase in SO2 concentration in lag 0 increased the risk of stillbirth. Not a very high increase, but the association was significant. Air pollution and preterm birth, again, time series analysis in Iran, they did find an increase in the preterm birth by 0.8 and 0.6% for 10-unit increase in PM 2.5 and NO2 respectively. Air pollutants and spontaneous abortion, case control study matched by several factors, so it was of a better quality than other case control studies in the region, and they found, based on data from closest monitors, significant associations for carbon monoxide, nitrogen dioxide, ozone, and particulate matter. Particulate matter was marginal again. There are several studies of Israel that are using large administrative databases and better exposure data. Studies that were looking at green space and low birth weight and preterm birth. Studies on temperature and air pollution with preterm birth and preterm premature rupture of membranes by Dr. Novak's group. Air pollution and preterm birth, or traffic air pollution and pregnancy loss. So we do have some good quality evidence coming from Israel. So having said all of these things, I think there are many issues that need to be addressed, at least from an epidemiological point of view in terms of these studies. First of all, there are limited number of studies for limited outcomes, which are definitely not enough to have a full view of what is going on in the region. There is a significant issue with how the epidemiological studies are using the exposures. They are at best using the data from the closest monitors, which are not good enough in most cases because they can create significant misclassification in what we see in the measures of association, and that you cannot be certain whether it is due to the lack of an association or the misclassification caused by not measuring it properly. Inconsistent exposure metrics that make the studies not comparable, not optimal control for confounding, the way the health data are obtained, self-reported data for last menstrual period and things that can have significant recall bias are indeed problematic. And studies of the area are small, so there were not proper power calculations and steps to prevent the role of chance, bias, and confounding. And with that, I would like to thank you and see if we have time for a few outstanding questions. I do not see anything in the chat or the Q&A. And we are indeed a bit behind, so I think we should move on to the next speaker, and we have the opportunity to have a discussion when all talks are finished. So our next speaker is Dr. Viktor Novak. Dr. Novak is the head of the Clinical Research Center and holds a senior physician position in the Department of Medicine at Soroka University Medical Center in Beersheba, Israel. Also a professor of medicine at Ben Gurion and adjunct lecturer at Harvard University. Dr. Novak's expertise includes designing prospective clinical trials and epidemiological data analysis. He has led and participated in the design of more than 40 pilot and pivotal studies for regulatory approval, predominantly in the area of cardiovascular devices. So Dr. Novak, the floor is yours.
Thank you so much for having me. I'm just trying to open my presentation. And so the kind of main topic of my talk today, and I think that it is something that we all share, it is that Middle East can be a time machine for research of the climate change. So basically what we see now happening with us here, that probably would be the future of the humanity unless something drastic will be done. And by nature, I'm not very optimistic. So our experience living in this area will be very handy in a few years. So what is this area that we are talking about? So we live here in Negev, and Negev is a desert. It is situated in southern Israel, and then actually half of Israel territory is in this Negev region. And it is in the middle of the global dust belt, as many other countries in this area. And our daily levels of particulate matter are much higher. Even our levels during the clean days are much higher than the WHO recommended standards. And sometimes during dust storms, and we'll see a bit of the pictures of that, these levels can go up by a factor of 100. So we started our journey quite a few years ago, trying to understand why we would be the best place to study the effects of the dust and excessive heat on the human health. And first of all, it's a hot climate. And this is a hot area, again, very similar to the rest of the Middle Eastern countries. The second is that we have this desert effect exposure also from a local desert and also from our exposure. The other reason it is that we have complete health outcomes records going back 30 years ago. Basically in Israel, in the early 90s, we started computerize all our health records, and because we have a national ID, so everything is accounted for. So right now we have a cohort of, say, babies born 30 years ago, and we can see in a longitudinal manner the effects of the environment and other factors on their life. And we count for any contact that our citizens have with the health system, any lab test, any imaging, any hospitalization, purchase of medication, and so on and so forth. And the last part is that we have a relatively accurate exposure assessment, both by stations and monitors the old way, and also by satellite methods. And so, just to make a point, and you all know this picture, and this is the picture from NASA from satellite, where you can see that the dust storm is approaching across the Mediterranean Israel shore, going into the territory, and the arrow points into our region. And so the picture that also Professor Carter shared with you yesterday, this is the campus of our university in one of the days. This is 12 noon, and then it looks like that. And again, those pictures are very familiar to everybody living in this area. And then within the next hour, it reaches the level of 5,000, and it looks approximately like that. And then you spend next week in cleaning. So what is our population and what is our setting? Within this Negev area, we have almost 1 million residents. We have two main ethnic groups, predominantly urban Jewish population and rural Arab Bedouin population that constitute about a quarter of our population. And in turn, the Arab Bedouin population, in 40% of the cases, they live in temporary dwellings, those are forcibly unrecognized villages. And so they have much higher exposure to the outdoor climate. Beersheba is the main city. It is 24,000 people, and this is where our hospital is situated. So on one hand, you can see that we have this relatively urban landscape here within the Beersheba. On the other hand, you have these temporary tracts that people are still living in such conditions. And so our climate is very similar again to what we heard previously. You can see that the temperature can be pretty high, and because it's a desert, it becomes very, very cold during the winter. So those are two sort of edges of our climate interval. We have monitoring sites. We have number of monitoring sites around the Beersheba, but also we have these hybrid models developed, validated by Itai Klug Group, and many of us are using his models. So the exposure to PM is predominantly non-anthropogenic in our case. We have no major roads here in the region. We have no traffic, for example. We have quite small industrial activity. We have industrial activity around the Dead Sea, but it is heavily monitored, so there is not a lot of pollution coming from this area for now. And again, as I already mentioned, we have these satellites that we can use for PM assessment. This flow chart is pretty familiar to everybody, and again, I must say that I'm pleasantly surprised that there are so many physicians in today's group and listening to us, because unfortunately, and I think that we all share this, we as physicians are rarely thinking about air pollution and climate as a trigger for the diseases. And this is not very common to ask your patient about the living conditions, but with the emphasis on the exposure. And there are not many courses taught in the medical school, but again, many of us, if not all of us, are physicians presenting our findings. And so our situation with the health is quite unique because we have only one hospital for the whole population. This is a large 1,100 bed tertiary hospital. It belongs to the same HMO, covering about 70% of the population, as I already mentioned. We have medical records going back 30 years, laboratory data, medications, and there are no loss to follow-up because of the national ID. So with these thoughts in mind, we start.
Sorry, Victor, sorry to interrupt. Sometimes we don't hear you very well. If there's a speaker that you can move, I think that would make a difference. Sorry.
I'm sorry about that. So just to repeat the previous one, that's the picture of the single hospital that we have here. And I work, can you hear me now?
Yes, much better.
Okay, perfect. And so this is 1,100 beds hospital. It belongs to 70% to the same HMO that covers 70% of population. Our EMR, electronic medical records, going back 30 years. And again, we have full access to this data, and we are all actually happy to share and participate in any research program that will require data sharing. We have no loss to follow up just because we have these national ID numbers. With these thoughts in mind, we started our journey, and since then we published quite a few papers, and we developed robust capabilities in terms of the research. And we participate in Panayotis research and other research programs from Harvard University. And we look into different aspects of the human health, including assessment of cardiovascular, respiratory, perinatal, mental, some strange papers like suicide behavior and meteorological characteristics, and so on and so forth. So we published and published and published, but the question is, so what's next? What did we learn from all these papers? So I would like to present just a snapshot of maybe a couple of them, just to show what are the questions that we're still dealing with. The first one was very straightforward. We just look into exacerbation of respiratory diseases, COPD, and we showed that during the dust storm, there is this 17% increase in hospitalization with the COPD exacerbations. And when we look on the vulnerable populations, which is the usual way how we look at this, we saw that actually two vulnerable populations are female and elderly. And again, we had some thoughts why those are most affected, but again, the same pattern. This dust has a health effect. Then we went to a field, and actually we wanted to see where is the change in FEV1 and COPD patients with the exposure to the dust storm. So we went and assessed them at the baseline and then 2 days after the dust storm. And actually what we saw there, we saw the complete mishmash of the different findings. Some increased this measurement, some decreased this measurement. There was no signal there. We repeated these things also in population with asthma, and we have again the same findings. It goes into different directions. There is no clear effect, at least not in our setting. Then we look into cardiovascular risks, and just an example for that, there are many cardiovascular risks and conditions that we looked at, but the main one that I would like to mention right now would be ischemic stroke. And what we showed there that actually both PM10 and PM2.5 are associated with increased incidence of ischemic stroke, but only in younger patients. So elderly, that was completely flat. So again, a strange group with a strange finding. Some of this can be just a statistical fluke, but we thought that there is something there. So we looked into actually a modifier effect of the proximity to the main roads, and we saw that only those who live around these main roads have any effect of PM10 or PM2.5. And then the question becomes, how do you actually distinguish between anthropogenic and non-anthropogenic dust? So what we saw actually in many of our studies, we saw this solid line. So basically when you plot any health outcome against your PM levels, you will have this effect initially going up, then you will have some plateau or even maybe decrease, and then it goes up again. And again, it was cited today, and we saw this in many of our papers. So we proposed a theory that actually what we see here, it is an interposition or summation of two curves. One explains low PM levels of anthropogenic pollution, which is much more biologically active. And the second peak in a higher region of PM explains actually non-anthropogenic dust. And then a summation gives you this biphasic pattern. With this thought in mind, we actually went and tested this theory, by which I mean that we actually look on the NO2 as a marker for anthropogenicity of the dust. And we thought that if we were right, then with low anthropogeneity at low PM10, we are not supposed to have an effect. And the opposite, if we have high anthropogeneity, industrial dust trap, and so on and so forth, we will have higher effect in low levels of PM, and the opposite for the high PM10. And so we tested this theory on two case scenarios. One was the blood glucose that actually behaved exactly as we predicted, but the second was asthma. And within the asthma exacerbation, we didn't find any correlation with the any support of the hypothesis that I mentioned right now. The next question that we had that was actually, what do we measure actually when we measure exposure? Because we all use ecological type of approach, and as you all know, first of all, it is based on monitoring station, some models that are validated on monitoring station, indoor, and there are many things that can be in the gap between indoor and outdoor concentration. So with this thought in mind, we thought about new paradigm, a new type of assessment, and we actually developed a collaboration with our National Blood Bank. In Israel, everyone who donates blood basically signs an approval that we can use his or her samples for scientific purposes. And so we started measuring some things in the blood of the donors, basically saying that at each day we have about 1,000 donors in Israel. They're distributed all over the country, and we can use them as biological almost markers for whatever exposure was there. And so for now, we concentrate on heavy metals, but again, this method probably will allow us actually truly assess on a population level what are they exposed to. Again, for PM, it's much more complicated than that. And I would finish with these things. So I'm frequently asked by my students and by other physicians, well, you're talking about some very, very small effects. We're showing the promal effects, especially with our non-topogenic past, how they are relevant. And the relevancy of this, I think, is very important because everybody is exposed. And the second thing it is, okay, so you say that we're exposed and we have to do something. What is exactly should we do? How exactly we should change the policies, how they should be overseen, who should be responsible for that, and what are actually, or what will affect actually the health of our population. And with this in mind, thank you so much for having me today.
Thank you, Dr. Novak. That was a great talk. I would invite any questions or comments or clarifications that anyone would want. So if we don't have any questions, we will move on to our next speaker, who is Dr. Mark Weiskopf. Dr. Weiskopf is the Cecil K. and Philip Trinker Professor of Environmental Epidemiology and Physiology in the Department of Environmental Health and Epidemiology at the Harvard T.H. Chan School of Public Health. His research focuses on how environmental factors affect the nervous system, as well as the epidemiology of neurologic disorders. Examples of his current work include exploring how exposure to certain toxicants affect cognitive function and psychiatric symptoms, how air pollution and other toxicants relate to autism spectrum disorders, and how toxicant exposures like formaldehyde and lead relate to the development of amyotrophic lateral sclerosis. In addition, he currently oversees a large study in Israel and Denmark to explore the relationship of currently used medications to ALS. So, Dr. Weiskopf, the floor is yours.
Okay, great. Thank you, Stephanie, for that introduction. And thank you, Petros and Eric and others for inviting me to speak in this. It's been a great 2 days, and I've learned a lot about the region and air pollution and dust storms. It's been terrific. Thank you. So I'm going to talk a little bit today about air pollution and cognitive function and dementia. It's one aspect of my work, but also something that's, of course, gaining a lot of interest in general. Let me start by just pointing out sort of a definition of dementia. This is fairly crude, I guess, but this is a big issue in dementia work, is how one actually defines it. But really, at the base, it reflects a significant decline in one or more domains of cognitive function, and importantly, decline that interferes with activities of daily living. It also has to not be better explained by some other disorder and is not occurring only with a period of delirium, which means really something else is behind it. So that sounds relatively simple, but it's in fact a pretty difficult diagnosis to really define precisely. And that leads to some problems with the epidemiology or difficulties in trying to look at how the environment may affect it. But you can also see from this definition why it's obviously very tightly tied to cognitive function and cognitive decline. So a lot of studies focus on that rather than necessarily the dementia itself. It's a huge problem, as you're probably well aware. This is a cartoon generated by a former doctoral student of mine who now does a lot of work in this area. It sort of takes some projections of Alzheimer's cases around the world. Each red dot here is meant to reflect 100,000 cases of Alzheimer's. This is where we were roughly in 1950. In 2000, it's getting worse, and you can look at the Middle Eastern region around here. And then, of course, the projections by 2050 this is actually probably somewhat old. This was 115 million projected cases. I think some estimates now are at 130 or 140 million cases by 2050. So it's obviously a huge problem and a global one. And so understanding even some modifiable risk factors for this would be hugely impactful from a public health perspective. Adding to the complexity of how we study these things is that it's not only can the diagnosis be a little bit fluid and difficult and can vary when it actually comes about. It's overall dementia is a very heterogeneous thing. So on the left here, there are many types of dementia one can have. We're all familiar with Alzheimer's disease, but there's also dementias that are considered vascular, that are frontotemporal, Lewy body, a whole slew of other ones. And there's a lot of overlap between these. And on the right, what I'm showing you is just one example, a study that sort of looked at the pathology underlying dementia. And when it took a sort of series of people at autopsy, among those diagnosed with dementia, you can see that a large fraction of them had Alzheimer's disease type pathology. Many had sort of vascular infarctions in there. A small fraction had Parkinson's disease or Lewy body type dementias, but probably the majority of them had a mixture of all of these. So it's not a clear thing. And then even more problematic from the epi side is that there was a fraction of these people who clearly had clinical dementia from a behavioral point of view that simply didn't show any pathology. So you can see that as well. And then in the contrast, or the flip side of that, is people without a clinical diagnosed dementia can also show a large fraction of them have no pathology in the brain upon autopsy, but many of them have all sorts of different pathologies as well. So trying to identify risk factors for this gets tricky when it's even hard to sort of focus on exactly what is going on in the brain. So you can see how all of this might lead to some difficulties in the study of this outcome. So why do we think that air pollution might be related? One place to go back to point to as one start, I suppose, is a study by Lilian Calderon-Garciduenas in Mexico, looking at dogs, actually, and taking brains of dogs in Mexico City, relatively polluted area from an air pollution perspective, and finding all sorts of, I don't expect you to know the neuropathology here, but all of these neuropathologies in all of these different slides are things that we wouldn't typically see in a brain, things like reactive astrocytes, degenerating neurons, ApoE, plaques and tangles, tau. And they're not just that. These are things that actually have a sort of fingerprint that looks a fair amount like neurodegeneration. And so Dr. Garciduenas was suggesting that air pollution may actually contribute to this. And she did studies comparing, in fact, dogs from the more polluted regions in Mexico City with less polluted areas or less polluted cities, and seeming to show that the ones in the polluted areas had more of this kind of pathology going on. So that was back in 2002. And it wasn't long after that the epidemiologists got on board and started looking at a lot of these questions. One of the first studies to come out on this was by Rampt et al. In Germany, that looked at the residential distance to a major roadway and in relation to some cognitive tests. CIRAD is a battery related to Alzheimer's disease, and showed a pretty strong correlation between worse scores on that cognitive battery test and living closer to a major roadway. That was back in 2009, and J.C. Chen and Joel Schwartz at Harvard at the time in 2009 looked at US, this was NHANES data, looking at US adults. The one above actually here in Germany was just women. This was both men and women, looking at ozone, county annual average ozone levels and performance on a variety of tests here. The specifics are not that important. They're executive function, working memory type tests, but did seem to find that for every 10 part per billion ozone increase, the scores on these tests went down, and that average, the sort of rough equivalency was the same amount of drop you might see after 3, 4, 5 years of age. They did not, however, see an association with PM10. We've done some work on this as well. Eric Garshik knows the normative aging study quite well. We've looked at cognitive function in this group. This was Melinda Power, my former doctoral student, looking at where the folks in the normative aging study lived in the Boston area. This is elderly men, using a black carbon model from Graparis et al. In 2007. and found that higher black carbon exposure was related to higher odds of having a low mini-mental state examination score, which is a dementia screening tool. But also we had a series of cognitive tests, and we've sort of combined them into a global cognitive function score, and found that as you doubled black carbon concentration, you got a certain number worse on that global cognitive score. So again, suggesting that some aspects of air pollution are related to worse cognitive function. That was just a couple. Those are some of the starts. This is sort of a rough, this is really just me doing a sort of rough finding of articles on air pollution and cognitive function or dementia over the years. And you can see that it kind of trickled along for a while and then has started to pick up. I did this back in 2019. I haven't updated it for 2019 and 2020, but I know just offhand that this would now skyrocket above even this level. So the research into this issue is definitely picking up a lot of steam, and there's actually lots of reviews out on all of these papers. This Melinda Power one is I highlight because it talks about some of the epidemiological difficulties of these kinds of studies, but there's some very recent ones as well that have sort of outlined all the research on this, and there is a lot of it, and overall, that there's a lot of the research points to an adverse effect of different elements of air pollution and either cognitive function or cognitive decline or dementia, to the point that the Lancet Commission in 2020 certainly put air pollution in there as a risk factor for dementia. Now, I take some issue with how they're basing that on, although I think in general they got the right message there. And so if we look around the world and what people have looked at, there are studies from many, many different places, although I will say I don't know how many, if any, are from the Middle Eastern region. That's a good question. But there are from various places in the world, obviously dominated from the United States, Canada, and Europe. And people have looked at a whole variety of different air pollutants, the different fractions of PM, nitrogen oxides, traffic indices like distance to road, chemical species, black carbon. And most often these studies find something with one of these air pollutants that they're looking at. The evidence is perhaps slightly better for fine particulate matter, PM 2.5, and maybe the nitrogen oxides. But all of these have in some places or other been suggested to be related to worse cognitive function or dementia. But there are definitely issues with this. A couple of them I've indicated here. Many of the studies actually just look at cognitive function at one point in time, and the examples I gave you earlier are examples of that, and that's certainly good. But there's a lot of issues, both sort of biological about what dementia is, as well as epidemiological about what you're looking at, that can raise some questions about that kind of study. So there's distinct preference to be trying to look at cognitive decline, how it changes over time. That, after all, is actually cardinal to dementia, is that the cognition is declining in a way that affects function. And there aren't that many studies actually of cognitive decline in the same person over time. So that's one issue. And then I mentioned, I didn't go into the details about difficulties in diagnosing dementia, but they're real. It's not easy to do. And a lot of the studies that are out there about dementia itself come from claims or medical record data that one could sort of broadly classify as kind of passive surveillance for this. And there are definitely issues with that. You start to mix in, things that might affect how quickly you get the diagnosis, as opposed to actually a biological process underlying this. So these are some of the issues that are still there for the epidemiology, but with those caveats in mind, there are still, the bulk of the evidence suggests something's going on. But as I say, I think the stronger studies relate to looking at cognitive decline over time, or dementia in the context of these cohort studies that are kind of looking at everybody. So they're assessing everyone to determine how cognitive function is going, or when they reach dementia, as opposed to just being indicated as such in a medical record. Now, what's actually happening with the air pollution? So you've heard a lot already today and yesterday about cardiovascular effects of air pollution that are well established. Also, people have talked today and yesterday, I guess, about diabetes, things like that. So there are a lot of these more well-established effects of air pollution that probably are one of the ways that air pollution could affect cognitive function. There's clearly a huge vascular component to dementia and cognitive function and decline. And so if you compromise the vascular system, it's not surprising you might get cognitive effects. And the same could be said for things like diabetes. What's a little more exciting in one sense or interesting is that there's a lot more understanding about ways that particles might get directly to the brain, and in particular through the olfactory bulb. So the olfactory bulb is sort of sitting out there in your nose. The receptors for chemicals that you smell are there, and they are actually a sort of quick route into the brain where you can potentially bypass the circulatory system, the lungs, and all of that. And particularly intriguing about this is that the areas that the olfactory nerve project to in the brain are limbic and temporal lobe areas that are very sort of front and center in Alzheimer's disease type pathology. So they sort of give you a direct access to very critical areas of the brain relevant for learning and memory and dementia. And so there's a little bit more understanding of this potential route. There is in fact also some studies, not only in animals, but there's studies on humans and air pollutants and olfaction, which one might expect that if that's one of the routes getting into the brain, that you might expect the sense of smell to be affected, which does seem to be the case in some data. There's also a fair amount of effort in trying to understand the underlying biology by using brain imaging, which is clearly a hugely important tool. This is an image from a paper of J.C. Chen's at USC looking at air pollution and sort of volume size, sort of cortical size. And so there's a lot of this going on, and it's very important. I've put a review down here about this kind of literature. Intriguingly, sort of imaging characteristics related to cardiovascular effects, it's not so clear that that's what's being seen in terms of the air pollution effects on the brain. But this is an evolving area of science and a very important one, although one that also has tremendous potential epidemiology issues, which is that it's not easy to get brain imaging on people. And so you have a lot of concern about who this is being done on and whether that's somehow affecting the results you're seeing that can complicate the interpretation of the results. But you know, that and animal work has sort of come up with several pointed to several different types of mechanisms by which air pollution could affect the brain. You know, we have a nasal pathway going through the typical route of respiration and the lung, systemic circulation. And we know we see things like systemic inflammation potentially affecting the blood-brain barrier, and therefore what else can get into the brain. So if you damage that blood-brain barrier, you can have problems. That can relate to altered neurotransmitter levels in the brain, neuroinflammation, oxidative stress, protein aggregation, and ultimately neuronal death in the brain. There's this pathway I mentioned, potentially directly through the olfactory bulb coming into the brain doing all of this. So multiple potential mechanisms are there to underlie a relation between air pollution and cognitive function. And all of the ones I've boxed in red here are negative consequences of particulate exposure that are evident in many neurodegenerative diseases. So in Alzheimer's, dementia, other types of things, we see neuroinflammation, oxidative stress, often damage the blood-brain barrier, things of that sort. I do want to point on this slide to one thing in particular, is the activation of microglia in the brain, which is sort of the resident immune cell inside the brain. So it's, you know, it plays a very important role, and I think deserves a lot of attention. And it's an area that I'm extremely interested in because it is the immune system. It's sort of on the front lines of responding to insult in the brain. And there's a lot more being understood about these microglia in general nervous system function, both in young age and old age. And in particular, it's been relatively recently described that these cells, so obviously we know they respond to sort of environmental insults, but they also play a very active role in kind of sculpting connections between brain cells in the brain. And they are the cells that are actually responsible in many cases for actively eliminating connections between two neurons. Now, often you want to do that in certain scenarios, but if you were to do that aberrantly and in a ill-advised or toxicant generated kind of way, one could see quickly how you're really right there at a key point of destroying sort of critical players in brain function and memory function. And so these microglia really sit at this interface of air pollution, response and critical functions that are relevant for maintaining appropriate neural structure. So I think a lot of interest is focused on these, and I'm hoping that will expand in the near future. So where are we now in terms of air pollution and cognitive function dementia? And I will say this is focused on cognitive function dementia, but as you just heard, there's also interesting stuff on neurodevelopment and air pollution, and mental health and anxiety, depression, air pollution. So those are important areas for which there's a fair amount of work as well. But just focusing on cognitive function and dementia at the moment, we do have a fair amount of evidence that something is going on, that air pollution is related to worse cognitive function. And the best of those studies probably deal with cognitive decline, of which, frankly, there are only a few studies looking at cognitive decline in the same people. And there are a few of these cohort dementia studies that I think are somewhat stronger. But overall, there's a large number of studies that all seem to point in this direction. There is still a lot of question about what pollutant matters. As I said, PM, and particularly PM 2.5, is of particular interest and seems to be more often seen as related than other parts, but there hasn't been a whole lot of exploration of the components of that particular matter. Gases definitely pop up at times. There's a lot of interest in ultrafines, with the idea in particular that they may be particularly good at getting directly into the brain, but there's really limited evidence, if any at all, on the ultrafines, just because of our limitations in getting exposure models or exposure assessments for that. So that's a huge area for future work. And of course, other hazardous air pollutants that are out there, and trying to look at these. There's a big question still about the how. Probably cardiovascular effects of air pollution are doing something, maybe the diabetes, metabolic ones, inflammation, is it direct action on the brain? There's a lot of work to figure out which of these mechanisms are responsible, and to what degree. Probably all playing potentially some role. And very critically, there's also the issue of when does this exposure matter? And this is really tricky. The vast majority of these studies, if not essentially all of them, have really looked at air pollution levels in the year or maybe a few years before assessing the cognitive function or before the onset of dementia. And is that really the relevant exposure window? That's a very interesting and unclear question. What I will say is that when we look at dementia, there's a lot of evidence that a lot is going on in the brain before you actually get a diagnosis. So this is derived from a study by Jack et al. Many years ago, but everybody talks about this. This is sort of a cartoon example of it. But out here is on the right is clinical diagnosis of dementia. Ultimately, the last thing being this clinical function. But before you lose a lot of clinical function, you have memory problems. Before that, when we do the right imaging, you have brain structure effects. We can look at different biomarkers, and this is to some degree changing all the time as our methods to detect this get better, but people keep sort of pushing this earlier and earlier. And you can see tau and mediated neuronal injury prior to brain structure effects, amyloid deposits earlier than that, and there's a lot of evidence that that a lot is already affected in the brain well before you clinically diagnose dementia, and even well before you might see sort of frank cognitive effects. So this becomes quite problematic to think about when we need to be looking at air pollution. It's possible it's way back here, starting something. It's also possible that the air pollution is aggravating and accelerating some of these processes. And so the more recent exposures may be very relevant. But this is still, I think, a big question out there. So with that, I just wanted to thank my group that I do all this work with, and in particular, so this is my group here at Harvard, and then former doctoral student Melinda Power, former postdoc Marianthi Kimortsoglu, and a former postdoc, Jennifer Weave, now at BU. Marianthi is at Columbia and Melinda is at George Washington, and they've done a lot, and they continue even without me to do a lot on air pollution and cognitive function. So I highly recommend looking them up as well. So thank you.
Thank you, Mark. That was wonderful. We do have several questions, so I think we should start our discussion session now regarding all the talks, but given the questions that came up for your talk. So Dr. Koutrakis is asking, have researchers studied the effects of smoking on cognition?
Yeah, they have, and that's a for many reasons. I mean, biologically, we might expect something to go on. There's also great concern about sort of genetics of who smokes and who doesn't smoke. One of the things that what is seen, you know, what the data seems to show is very intriguing. There are papers written about this because it's an interesting epidemiological issue, which is that if you look at smoking late in life, so if you get your cohort in the 70s and 80s, and you look at smoking and dementia, you actually tend to see a protective effect of smoking. But if you start your cohort much earlier, when they're 40 or 50, you see smoking as a risk factor for dementia or cognitive decline. And it's strongly suspected that what's going on there is that smoking is leading to competing effects, even dying, so that those people are not around when you try and get them at 70. So the few people who smoke who are left at 70 are very different. And so you're getting a selection bias effect. But so when you start earlier, before those effects have a chance to do as much damage, we definitely see smoking as a risk factor for cognitive decline and dementia.
Another question is, are there any studies on mood disorders in areas with higher air pollution levels?
That's a good question. The mood disorders is actually somewhat newer, those studies, than, I don't know if others on this panel would know this better. The ones that so we did one in the Nurses' Health Study. There have been some, I believe, from Europe. I don't remember whether there are any in China, but so I'm not sure about that. My initial reaction is no, but I'm not totally sure.
Dr. Novak, you want to add something?
Again, I think that this is maybe is coming from the same participant that asked this previously. There was some evidence that trying to connect meteorological factors with the sort of acute disturbances of the mood, but not long-term effects. So long-term effects, I'm not aware of any study that was done in this particular area.
Yeah, and in fact, I'd say that in our study of PM and anxiety symptoms in the Nurses' Health Study, that the evidence seemed to suggest, although it was not the best setting for this, but it seemed to suggest that it was the more recent experience, like in the last month, was more important than in the last year.
Then it's a question from me. I was wondering, the last slides that you showed are so interesting in outcomes like cognitive decline, which may start like many years before the actual clinical diagnosis that you use as the point that you set your outcome. So I was wondering, how did these studies or your studies look at, where someone lived like way back to assign the exposures, or the recommendations, like what really matters, where you are exposed at the beginning or during the course of the development of the disease, or, I mean, how do you tackle those issues when you're analyzing this data?
Yeah, well, I'd say, frankly, that essentially has not been done yet. I believe Melinda Power at George Washington tried to go back maybe 5 or 10 years prior to a diagnosis, or at least to the cognitive testing to look there. But as I say, most have looked maybe in the year of the testing or the year of the diagnosis, maybe a few years before that. It's hard in part because the models for air pollution don't go that far back, right? If you're talking about someone who's 70 now or 80 now, what happened earlier on. But it's worth certainly looking into, even if we could sort of crudely, crudely bin them into kind of higher or lower exposure levels and see whether that matters. As I say, I'm not yet sure about whether I would expect that earlier time to be more important, or whether it's more recent exposures that lead to more acute neuroinflammation that maybe accelerate some of the processes that are already underway. So it's a very difficult call. I will say I'm very interested also in the question of metals in general. Now, some of the metals can of course come from air pollution, but I have a study underway to use teeth in elderly people as a biomarker of their very early exposure to metals, to see whether that is related to subsequent Alzheimer's later on. And if we could try and do that in some way with air pollutant levels, that would be great. But that exposure assessment side is tougher. But there's studies, there's very famous studies from the Rush Institute of Aging in Chicago about nuns they have a study of the religious orders studies. And what they found was that they went back and they looked at the essays these nuns wrote to get into the seminary or the nunnery back when they were all 18. And they are able to show that the ones that later developed dementia had, different writing. It tended to be less complex and at a different level when they were 18. So something is going on even way back earlier on.
I would just add here that just remind the studies I presented in childhood, where there were in some of them clear evidence that there is delay in psychomotor development of children by exposure to air pollution antenatally, but also postnatally. And although I'm not the best equipped person to assess the test that they have used, it appears that there is an effect there.
Yeah, and then those things sort of snowball throughout the life that may lead you to earlier dementia diagnoses later too.
Dr. Koutrakis says that we just published a paper where we found radon progeny in different locations of the brain. Dr. Koutrakis, do you want to say something about that?
Not, but I think that's another indication that you can have ultrafine particles going from the auditory bulb to the nerve, to the epithelium, to the bulb and the frontal lobe. And I think that's very, trying to understand radionuclides in the brain. It's a very sensitive way to really understand exposure, and also to see how long the exposure has happened. So I think I do believe that radon also has something to do with, all these radionuclides to throw alpha particles in the brain continuously for smokers or other people who are exposed.
And also, you ask why brain diseases have been increasing. Is it because of aging population?
Only. Is it only?
Yeah.
Right. So that's definitely a huge contribution, is the aging of the population. Intriguingly, though, and I actually don't know where this stands at the moment and exactly all that's behind it, but Bert Hoffman, the chair of epidemiology here at Harvard, has done a lot of work on sort of trends of Alzheimer's and dementia, and actually suggests that the incidence may be decreasing.
Yeah, it's good.
Now, it's not exactly clear why, but part of that is that it seems to be decreasing beyond what would be expected from sort of changes in cardiovascular and other kind of known risk factors for that. So, so that's an intriguing point to follow up on. But it's also hard to. There's so many things affecting that overall trend that it's a little hard to tease apart. But that does seem to be what the trend is showing. I see also John Vandenberg asked a question about studying ultrafine particles and translocation. I have not, but let me put in a plug. Actually, we haven't got the flyer out yet, but I'm hosting a symposium on March 15th from 11 to about 1:30 in Boston time on air pollution and dementia. And one of the speakers is Gunther Oberdorster at Rochester, and he has done a lot of work, and he's going to be talking on that question actually.
Great. Well, we'd like to see your flyer when that's available. So thank you. I actually have another question for you. We've had a lot of evidence here in the last 2 days of pretty extreme dust levels. And again, I recall when I was in Saudi Arabia, you couldn't see the sun because the dust was so intense. Here in the United States, we've had tremendous problems with wood smoke in the western states, especially this last year. Moving away from the sort of biological, but towards the visual and sort of behavioral, do you find that people are depressed, that they have evidence of behavioral changes because of the levels of environmental conditions that they're seeing, and that affects their mood, their well-being, their sense of well-being? Is there any evidence along those lines?
Yeah, so I would have to say not that I know of, but not that I would necessarily know it. So I don't know if other panelists want to comment on that. I mean, as I say, there are these studies looking into sort of, is there an association between a given pollutant level and depression and anxiety? And there does seem to be something there. How much of that, if any, or what would happen when you got to a level where it's sort of noticeable and
Right.
Therefore having that kind of behavioral reaction to that? I'm not sure. I believe there are people who are trying to look at things like those wildfire smokes and say, what are the sort of mental health aspects of that, even considering things like PTSD because of the trauma of having to go through something like that. So I believe there's work on that, but I don't know that literature fully.
Because we have the air quality index that indicates the quality. So my son lives in Oregon and had very, very high levels of PM this summer with wildfires there. And there was definite behavioral changes by people that were, kind of informed by the public health community to stay indoors, reduce your exposures, don't exercise outdoors, that kind of thing. But I just wonder how that does weigh in terms of mental health and the long term, not just in the smoke, but also in the Mideast, where you've got that sort of typically that dust that can be very intense. So just it's an interesting area, I think, to consider.
Actually, for us, those events tend to be very short. So we don't have a long event. The longest can be like 3 days. And again, more intense, shorter days. So that's one. But second, actually, everybody is cursing because you have to clean a lot. So there is no time to be depressed. You just clean.
Okay.
Great.
And
So
Petros, I was going to add to Petros's the radon story, not exactly the same, but your colleague down there in Sao Paulo has shown sort of the collection of particles in the brain following, I think he's equated like an hour in traffic in Sao Paulo to a pack of cigarettes or something, but he's right, something along those lines.
And he has thousands of cadavers, that he can do whatever he wants.
I do not see any questions. So I would like to ask Professor Koutrakis and Professor Kesan Fusti to provide the closing remarks.
And Eric also.
And Eric, sorry, yes, I'm sorry.
Eric, you want to say something?
You are on mute.
On mute, that's better. Okay. I actually think what Victor talked about today regarding source and anthropogenic versus desert dust is fairly important. And, we've been using particle mass as an indicator of exposure here in the US and in Europe primarily, and even in China. And we don't have these dust events to the same extent clearly in the Middle East. And it's much harder to mitigate dust storms than mitigating local pollution or regional pollution. And I think that looking at sources, source apportionment, and health effects would be a very important thing to do in this region. And I wonder if some of that is explaining some of the heterogeneity of effects we're seeing for the short-term effects of dust storms, that there are mixed effects of desert dust with more mass perhaps, and also just pollution from other sources that's being carried along with the desert dust. So I think this is an important area to address in future work if your people are writing grants and hypothesizing how to integrate exposure science into the health effects part of this. Petros, maybe you want to add something to source apportionment.
Yeah, well, I was going to say that Eric and I, we have a very strong interest to understand the health effects of air pollution during the deployment. We have this large Veterans Administration study. So I think these discussions and these papers were very helpful, and I really appreciate the work that the speakers put to summarize what is going on in the area. I am very impressed because I think there is more than I originally thought. So I learned a lot during the last, today and yesterday. Unfortunately, we did not do this in Dubai or in another location there where we could have brought more people together and have more interactions. Obviously, there is a lot to do, and hopefully we will continue engaging through our connections there and friendships in this part of the world. Again, I think that we are training new people, and I was happy to see some of the younger investigators, presenters, that they have the energy and the knowledge and the drive to tackle the issues in this area. But I think also education is very important, and communication is very important, and trying to convince the people that there are problems there that they need to be tackled. So I hope the proceedings we will put together will reach the desks of people that they make decisions, or they can initiate research or discussions. I think I learned personally a lot, and I hope the audience, the people who attended, learn also quite a bit. And hopefully we can do this and similar activities in the future, and build a capacity, a network of people that they can get together and talk about these issues. It's really refreshing. Salman, do you want to say something? And if you have any kind of words of wisdom, and where to take this from here.
Well, thank you, Petros and Eric and all. You know, this has just been a really amazing session. I've learned an incredible amount, and in fact, I think it's more frightening than we originally thought. So I want to congratulate everyone on this. And like Petros, I think that there's a lot to do, and we have to sit together more and think about how to feed this better into public policy, because I think we've had doctors thinking about this and scientists thinking about this, and it hasn't really penetrated the space where people are thinking, I don't want to use jargon, but across sectors, about how to fix this. So I think this is really critical. So thank you, everyone. What an amazing couple of days, and hopefully we'll meet again. Thank you.
No, I just add on to that. I think if you're a regulator and a healthcare administrator, you had a diabetes clinic, or you're treating lung cancer in the region, this has implications for health and ultimately dollars spent and increasing productivity. I think that the EPA has done a number of cost-benefit analyses looking at the effects of controlling pollution. Even though it's expensive, it pays off in the long and more productivity, lives extended, and dollars saved. Maybe John can comment on the health benefits and the societal benefits.
Of course.
Get this to work for me. I think that there are significant benefits to public health from the research that arises, that we assess, that we inform the risk managers about it. But there's this parallel process of cost-benefit analysis that takes place. And usually the folks that do that, the economists, they're searching for the exposure-response relationship, searching for the key evidence that actually lets them feel confident that the risk and exposure and benefits can be evaluated. So I think that this research is really important. It's unusual here in this case in that you're dealing with the extreme cases of exposure with the dust, in particular in the Mideast. So one of the things that I would point to is the delineation between I'll call it total suspended particulate versus PM10, which is the inhalable fraction, versus the fine fraction. And that's where I didn't really hear in some cases that it was PM10 minus 2.5 co-located with PM 2.5 monitors, because that is an important distinction that will be informative to sort of the decision makers when they're setting standards, because PM10 captures all of that, PM fine and coarse fraction. And what, at least in the United States and also in Europe, you've got a distinction there between fine fraction and coarse fraction, which is between often combustion sources versus crustal sources. And I think in the case of the dust in the Mideast, it's some combination of that. So I would just encourage people to move towards defining whether it is PM10 minus 2.5, PM 2.5, or total suspended particulate is all going to be very informative. That'll help inform both the standard setting, but also the risk and exposure assessment. Hope that gets to what you're asking there.
I think I think merging regulation, exposure science, and health is very important. And that's the purpose of these meetings. You know, what do people want to hear in terms to translate it to public health?
Yeah, exactly. Exactly. Well, I think this has been a really important start. So thank you, everyone.
You know, one of the points, just to make a point, I asked a question about ultrafines because we don't have a separate standard for ultrafines. Do we need one? I don't know. In the atmospheric processing, ultrafines, you know, sort of agglomerate and become the fine fraction over time. But that has been one of the open issues, particularly the last presentation about the translocation from the olfactory bulb into the brain. It seems like Gunter Oberdoster has, you know, done a lot of work in this. Is that a critical particle fraction that we should really look at from a regulatory point of view? Because it really hasn't been done that much. And so that's an open question. So I just put that out there as another comment.
So just to comment on that one is, I know some folks, Roel Vermeulen and others in Netherlands, I think they're within, maybe around Amsterdam, they've got some monitoring and they're starting to do stuff to try and look at ultrafines. But from my perspective as the epidemiologist, I would love more exposure assessment help to be able to apply, you know, look at studies like that can track those.
And we do have the ultrafines at the Conway Library, Mark, that we have the longest time series that exists on this planet. So you can use that if you want.
I would say that
would be great.
For our region here in Middle East, you know, we during these last 2 days, we all noticed that we have very high levels of PM. And again, I completely agree that you have to delineate effects of 2.5, 10 minus, and so on and so forth. But we have such a high levels, and yet such a minuscule health effects that it almost it doesn't bring back the theory that this is not harmful, but it certainly shows that the epidemiology and health effects of quote unquote our dust are completely different from whatever you see in American cities and in European cities and even in China. It's different epidemiology, it's different effects, different assessments, I even would say. And so it's sort of not a personal complaint, but yet sometimes showing these very small effects is very challenging to even publish papers with this type of effect, because everybody is expecting 20%, 15%, and what we show, it is minuscule promils of the effect on a very high PM levels. So I think it's a very important to understand this through kind of local eyes, what we are dealing with.
Excellent.
Yes.
So before
Great.
we...
So if there are... Petro, sorry.
No, you want to say something? No, I was going to say a joke. There was a conference in Chicago many years ago, and there was a big storm. It was Friday. It was the last session of the conference. So there were two people left in the room. So the chair calls the last person to give the talk, and after the person finished the talk, start to go away, and the chair said, "No, don't go away. I am the last speaker. So before we deteriorate and go down to 5 people, I think we should really end this on time and thank the speakers for the great job they did." And Stefania, do you want to say something?
I would just want to thank all the presenters today that for the wonderful presentations and for being on time and being on schedule.
And stay in touch.
Stay in touch.
We will.
Thanks, everyone.
Thank you, everybody.